नमस्ते सबै जति पनि हाम्रो स्पिकरहरू हुनुहुन्छ त्यस्तै गरी हाम्रो गेस्टहरू हुनुहुन्छ सम्पूर्ण डाक्टर साहबहरू हाम्रो नेपालबाट युकेबाट र विश्वका विभिन्न देशहरूबाट जो पाल्नु भएको छ सबैलाई एनडीए युकेको तर्फबाट स्वागत गर्दै म डाक्टर कमल अर्याल भाइस चेयरम्यान अफ द एनडीए युके सम्पूर्ण महानुभावहरूलाई म स्वागत गर्न चाहन्छु र यति भन्दै म हाम्रो डाक्टर रमेश कोजु चेयरम्यान अफ नेप्लिज डक्टर्स एसोसिएसन उहाँलाई एक दुई शब्द स्वागत गरिदिनु हुन म अनुरोध गर्दछु त्यसपछि म एक दुई शब्द भन्नेछु धन्यवाद डाक्टर रमेश कोजु
नमस्ते सबैलाई स्वागत छ एनडीए को तर्फबाट आज चाहिँ हामीले विशेष गरी नेपालबाट प्रदेश 1 बाट साथीहरु आउनु भएको छ डाक्टर सूर्य पराजुली अनि डाक्टर शंकर प्रसाद अधिकारी उहाँहरु चाहिँ प्रदेश 1 को चाहिँ चीफ मिनिस्टर साहबको हेल्थ एडभाइजर कमिटीमा चाहिँ उहाँ इन्भल्भ हुनुहुन्छ र संयोगवश हाम्रा स्पिकरहरु सबै प्रदेश 1 सँग सम्बन्धित छन् डाक्टर अनुप कार्की उहाँ प्रदेश 1 घरको खोलुङ्गा भयो अनि डाक्टर नवराज सुवेदी पनि प्रदेश 1 धरानबाट नै एमबीबीएस गर्नुभएको भन्दाखेरि हामी चाहिँ करिब चाहिँ प्रदेश 1 सँग नै कन्सन्ट्रेट गर्दैछौँ र अनुप चाहिँ हाम्रो वेल्सको पब्लिक हेल्थ कन्सल्टेन्ट हुनुहुन्छ उहाँले वेल्सको बारेमा वेल्समा चाहिँ हामीले कसरी कोरोनामा चाहिँ प्रिभेन्सन प्लस अनि अरु अलि के गरेछ त्यो भन्ने हुनुहुन्छ अनि नवराजको चाहिँ आज विशेष गरी क्लिनिकल विषय रेडियोलोजी एकदम महत्त्वपूर्ण विषय छ र उहाँको चाहिँ धेरै एक्सपिरियन्स छ कति बिरामीहरु उहाँले चाहिँ हेर्सक्नुभयो उहाँको एक्सपिरियन्समा चाहिँ हामीलाई सुनेर हामीले धेरै फाइदा हुन्छ नि मैले आशा राखेको छु र कमल
थ्यांक यू डाक्टर रमेश हाम्रो एनडीए युके को तर्फबाट हामीले 4 अप्रिलमा जब कोभिड-19 को महामारीको चरम पिकमा रहँदाखेरि हामीले नेपाली डाक्टर्स एसोसिएसनको जो फ्यामिलीहरु हुनुहुन्छ युकेमा एक आपसमा के सपोर्टको लागि सुरु गरौँ भनेर हामीले यो प्रोग्राम सुरु गर्यौं सुरुमा हामीले एक आपसमा कसरी प्रिभेन्ट गर्ने कसरी जोगिने भन्ने कुरालाई र एक आपसमा कसरी सपोर्ट गर्ने भन्ने कुरालाई लिएर एक दुई सेसनहरु कन्डक्ट गर्यौं त्यसपछि के भयो भन्दाखेरिमा हामीले यसलाई के एजुकेसन गरेर सम्पूर्ण साथीभाइहरु जो देश विदेशमा बस्नु भएको छ सबैलाई इन्क्लुड गरेर के गर्न सकिन्छ कि भन्ने उद्देश्यले हामीले सुरु गर्यौं सुरुको अप्रिल महिनामा प्रत्येक हप्ता गरियो तर मे जुनमा प्रत्येक 2 हप्तामा विभिन्न थीमहरु लिएर चाहिँ हामीले गरेका छौं त्यसै उपलक्ष्यमा आजको थीम रहेको छ पब्लिक हेल्थ अनि त्यसपछि रेडियोलोजी यसभन्दा अगाडि गरिएका कुराहरुमा रेस्पिरेटरी मेडिसिन अनि त्यस्तै गरी एक्सिडेन्ट इमर्जेन्सीमा छँदाखेरिको अनुभव र त्यस्तै गरी वार्डमा म्यानेजमेन्ट गर्दाको अनुभव इन्टेन्सिभ केयरमा म्यानेज गर्दाको अनुभव यस इन्फेक्सस डिजिज यी कुराहरुलाई विभिन्न फोकस गरेर हामीले 8 वटा आजको 8औं हो र यस उपलक्ष्यमा म हाम्रो सम्पूर्ण स्पिकरहरुलाई म विशेष स्वागत गर्न चाहन्छु र आज हामीसँग 3 जना स्पिकरहरु हाम्रो डाक्टर रमेशले भनिसक्नु भएको छ उहाँहरुलाई स्वागत गर्न पाउँदा हामीलाई अत्यन्तै खुसी लागेको छ र अघि डाक्टर रमेशले भन्नुभयो प्रदेश 1 सित हामी कनेक्टेड छौं आज भनेर त्यसै उपलक्ष्यमा मलाई आज भन्दा करिब 23 वर्ष अगाडि मेरो जब क्यारियर कलकत्ताबाट एमबीबीएस पास गर्न साथै धरानमा आएर काम गर्दा 6 महिना अगाडिको अनुभव आउँछ र त्यसै अवस्थामा हाम्रो डाक्टर बालकृष्ण भट्टराई डाक्टर साहब हुनुहुन्छ उहाँसित आज भेटघाट गर्न पाउँदा मलाई 23 वर्ष अगाडिको फन्ड मेमोरिज भनौं त्यो उसको सम्झना आइरहेको छ र यति भन्दैमा हाम्रो प्रथम स्पिकर डाक्टर सूर्य पराजुली उहाँ चाहिँ कम्युनिटी मेडिसिन बिराट मेडिकल कलेजमा कार्यरत हुनुहुन्छ र त्यहाँको फ्याकल्टी हुनुहुन्छ र त्यस्तै गरी उहाँ चाहिँ he is also the member of the expert team who is advising the chief minister in province 1 so we are very grateful for your presence and we would like to welcome you warmly and the floor is yours thank you Dr. Surya Parajuli र यसमा चाहिँ when the slide uploads हजुरको स्लाइड
शेयर गर्दै छु सर
ओके when you are uploading the slide, के गर्ने छौं भन्दाखेरि डाक्टर सूर्य पराजुली सुरुमा, त्यसपछि डाक्टर अनुप कार्की र डाक्टर नवराज सुवेदी र बीच-बीचमा क्वेशन एन्सरहरु हुनेछ। त्यस गर्दै चाटमा पनि तपाईहरुले क्वेशनहरु राख्न सक्नुहुनेछ र हाम्रो डाक्टर रमेश खोजुले उता फेसबुक लाइभमा हेरेर हामीसित फिडब्याक गर्नुहुनेछ। धन्यवाद। हजुर सुरु गरौँ।
Okay, सबैलाई नमस्ते. Thank you for giving this opportunity to present, interact, and to find some solution of ongoing COVID-19 in the global context, and especially in our province number 1, Nepal. So before starting my presentations, I would like to thank our team, our coordinator, Dr. Shankar Adhikari sir, so he's here. And with his guidance, so we are doing our teamwork for betterment of COVID-19 prevention, management, and control. So today, basically, we'll discuss situation update and SWOT analysis of COVID-19 at province 1 of Nepal. So hopefully I'll speak Nepali and English, both languages. Is it okay, sir? Nepali, English,
whatever.
Okay. So I'm working at Birat Medical College and Teaching Hospital, and also as a fellow of Translational Research for NHLBI granted Dhulikhel Hospital, Kathmandu, and working as a member of medical expert team and province 1 representative COVID-19 task force through Nepalese Society of Community Medicine, NESCOM. So you can see, so after outbreak of COVID-19, there are gap between knowledge and practice. Okay, there is another gap between different ministries. There is another gap between public organization and private organization. There are so many, media rumor or infodemics. So I don't know. There are some problems, ongoing problems within province, and Chief Minister thought that he needs one expert team to guide him for ongoing activities, for policy brief, actually to implement the policy released by Minister of Health and Population or federal government in the provincial context. So we had team members from different expertise, and these are some of the photographs, snaps clicked during our work. Okay, it's ongoing work, and just showing photographs with meeting with our Chief Minister, Sherdan Roy. So in this slide, you can see this is a globe, and this is our new map, and we belong to eastern part of Nepal, and we have at a glance we have 14 districts in our province, having 25,905 square kilometer. And interestingly, we have lowest elevation 70 meter to highest elevation of the whole 8,848 meter, with population of 45 lakhs according to census 2011. Now it's around maybe more than 50 lakh in the 2020. And we have 6 ministries. This is especially provincial ministry, and we have 137 local government. 1 metropolis, 2 sub-metropolis, and other rural areas. Okay, so regarding the total healthcare institutions in our province, so we try to map, okay, the healthcare institutions providing different services like preventive services, promotive services, curative services, even rehabilitative services, and other special services. So we have 3 medical colleges affiliated. One is B.B. Koran Institute of Health Sciences, and another 2, Birat Medical College and Noble Medical College. Those are affiliated under Kathmandu University, and there are other proposed medical colleges like BNC, somehow in Dhankuta. They are going to establish another medical college in Purvanchal University Teaching Hospital. We have NGO-based hospital, Amda Damak, Amda Mechi. We have zonal hospitals, now it's Kosi Hospital and Mechi Hospital. We have 14 district hospital. We have 4 upgraded PSC. We have primary health center, private hospital, 100 bed, 8, 50 bed, 17, private hospital below 50 bed, 15, eye hospital, different eye hospital run by NGO, army hospitals, snake bite treatment center, and at the grassroots level, female community health volunteer. This is, somehow our force for healthcare delivery or healthcare service delivery. So this is the real mapping of our province number 1 of Nepal. And we have many, polyclinics and the clinic and other services like not only modern medicine but Ayurvedic, some service centers for Ayurvedic treatment or somehow homeopathic treatment, other herbal medicine, and even the traditional medicine, traditional system of healthcare exists in our province. So regarding media, we have 108 FM radios within province, 108, okay, within province, and we can listen other FM radios from different province and even from national radio. We have 150 online media, 7 television stations, and almost 28 print media, and many more journalists, registered journalists. Nowadays, it's a little bit confusion. What's media? What are the journalists? What is health journalism? Because in the context of any pandemic or outbreak, the rumor is or infodemics or information overload is one of the major challenges to manage outbreak in a local context or in the global context, maybe epidemic or pandemic. So we need to really think about media or the communications. So this is topic of discussion for today's presentation as well. So regarding some plan, policies and the guideline by province 1 and our federal government, and now it's a usual website. सबैलाई हामीलाई थाहा छँदैछ हाम्रो federal government federal COVID-19 dedicated website. So you all know this website. You can just click and you can access this website, and you can get almost all information related to COVID-19 and situation report of Nepal. So we have federal with province 1 update. Okay. So in their site report, every day they used to release a site report in English language and in Nepali language. Okay, and they included, I think, since last 7 or 8 days, they included the data of province 1 separately in a separate page. So I just want to see you here. So okay, just fine. So this is a site rep means situation report of our Minister of Health and Population. So it's freely available in their drive, and if we click this document, okay, now we can find all the situation of our country. Okay, let me. So we can see this is a situation report of our country, and so they try to put good graphics for good visualization. And they are trying to compare the distribution of COVID-19 cases, desired death, and most important part is now province number 1. So they published link of different guidelines produced by province 1. Okay, province 1, as well as the recent or latest data of province 1 from different districts. So we have 14 districts. So till now we have only 1 district remaining without having any COVID cases, without any notification of COVID-19 cases. That is this is Okaldunga. Except Okaldunga, we have cases from all districts. And we can find latest update from this drive link from Minister of Health and Population. So regarding province 1 COVID-19 website, so we have a website of Ministry of province 1 Ministry of Social Development, mosd.un.gov.np, and we have separate menu COVID updates. Okay, so you can get latest information regarding media rumor and infodemics. So we need to suggest our general population or media for actual sites or the real site of government. And regarding the latest update of province number 1, we can find all the latest update here. Just I want to show you latest update of province number 1. Okay, see, this is the latest update of province number 1, and we can see the actual real data of province number 1 related to number of isolation bed, number of ICU, number of suspected cases. And regarding total number of cases, till now we have 186 person who are PCR positive, and they are isolated in different COVID hospitals of different level. And we have already 234. Today we have updated list, but this is tomorrow, and we have no deaths till now. So this is interesting one. This is good one, actually good one for province, our province, and you can find all data for data scientists. So we can go through latest data of province number 1, so that we can analyze, we can give our we can analyze, and we can give our suggestion based on data, based on evidence. So it's freely available in the province 1 website. Actually, this is one of the good part of province 1, and we cannot find all the information of other provinces, especially province number 2 and our surrounding, our nearby province. Okay, you can see it's clearly available. We can just go through all the data, we can analyze. Even they try to put the logistics of province number 1. So in the current date regarding PPE set, so we have received up to a study of 1,518 set of PPE. Now they already distributed 1,347. Now the remaining stock balance is 171. अब अहिलेसम्म प्रदेश सरकारसँग चाहिँ 171 मात्रै PPE छ भनेको छ। भनेपछि N95 मार्क्स कति छ, हामी सबै कुरा चाहिँ यहाँबाट हामीले एक्सेस गर्न सक्छौँ। भनेको डेटा सोर्सबाट चाहिँ हामीले धेरै कुरा, एक्सपर्टहरूले डेटा पायो भने चाहिँ धेरै कुरा गर्न सक्दो रहेछ भन्ने कुरा चाहिँ हेर्न सकिन्छ। यो चाहिँ सबभन्दा स्ट्रेन्थ प्रोभिन्स नम्बर 1 को अहिलेको लेटेस्ट स्ट्रेन्थ। यो अपडेट भनेको चाहिँ असार 1 गतेबाट चाहिँ धेरै नै अपडेटहरू गर्न थालेको छ। यो चाहिँ एकदमै राम्रो कुरा पनि आएको छ। ओके, त्यसपछि अरु कुरा गर्ने हो भने रिगार्डिङ गाइडलाइन्स अफ प्रिभेन्सन एन्ड म्यानेजमेन्ट कोभिड-19 इन्फेक्सन 2017 has been endorsed and implemented at province level, and we can assess this guideline from this drive link or from their website also. COVID-19 संक्रमण रोकथाम तथा व्यवस्थापन मार्गदर्शन 2076 जुन यो गाइडलाइन आयो, नेपाल सरकारले एउटा गाइडलाइन ल्याएको थियो, तर प्रदेश सरकारले पनि केही मोडिफिकेसन गर्यो। यसमा अब धेरै डाक्टर शंकरहरु हुनुहुन्छ, डाक्टर प्रज्वलहरु हुनुहुन्छ, अरु धेरै एक्सपर्टहरुको छलफलहरु भयो from public health background, from community medicine background, from clinical background, lab background, and from alternative medicine background like Ayurvedic and other, and we have many policy meeting with different stakeholder ministers or the experts. Then province 1 released COVID-19 संक्रमण रोकथाम तथा व्यवस्थापन मार्गदर्शन। यो चाहिँ सबभन्दा प्रदेशको सबभन्दा राम्रो गाइडलाइन नै भनौं न, गाइडिङ डकुमेन्ट यो थियो। यसले चाहिँ काम भएको थियो, तर च्यालेन्ज के थियो भन्दाखेरि इम्प्लिमेन्टेसनमै थियो। त्यसपछि यो CICT केस इन्भेस्टिगेसन कन्ट्याक्ट ट्रेसिङ टिम बनाउनु पर्छ है भन्ने कुरा आयो। जब चाहिँ कोरोनाको केसहरु बढ्दै गयो कोभिड-19 को, त्यसपछि यो कुराहरु आयो। त्यसपछि नेपाल गभर्नमेन्टले ल्याउँदै गर्दा पनि प्रोभिन्स 1 ले पनि चाहिँ कोभिड-19 संक्रमित खोज पडताल तथा सम्पर्क पहिचान मार्गदर्शन भनेर स्पष्ट रूपमा यो चाहिँ मार्गदर्शन ल्याएको छ। यो SOP स्ट्यान्डर्ड अपरेटिङ प्रोसिजरहरु बनाएको छ। यस टोलीलाई महामारीका लागि तयारी तथा प्रतिक्रिया विषयमा जानकार महामारी विज्ञ वा जनस्वास्थ्य विज्ञको हरदम सहयोग रहनेछ, सुनिश्चित रहनुपर्छ भनेको छ। उनीहरुले के रियलाइज गर्यो भन्दाखेरि चाहिँ so we have महामारी रोग विज्ञ, we have community medicine specialists, we have epidemiologists, we have MPH experts or public health professionals. So they need to involve for guiding CICT team. So this is one of the beauty of this document. Another important part is सामाजिक मूल्य मान्यतालाई परिचालन गर्दै सञ्चार गर्न सक्ने सिप भएका व्यक्तिको संलग्न हुनुपर्छ। So we need to feel the real pain and gain of our society, our social culture, norms. And we must have good communication skills to communicate with COVID people or their family members or the community. So these two are the strong points, and it has almost all the standard operating procedure, all the guidelines, all the instruction for how to form group for CICT. Okay, and they recently released a protocol for pool testing of COVID-19 2077. किनभने अब हामीले टेस्ट भनेर आज टेस्ट गर्नुपर्छ, तर अब टेस्ट गर्नको लागि हामीसँग PCR मेसिनको पनि ल्याबहरु पनि बढिरहेको छ, PCR क्यापेसिटी पनि बढ्दै गरेको छ। भोलि अब लोकल कन्टेक्स्टमै पनि मेजर आउटब्रेक भयो भने, अहिले त मेजर आउटब्रेक भन्न सकिन्छ जस्तो लाग्दैन मलाई। त्यो भन्ने हो भने चाहिँ भोलिका दिनमा वी नीड टु गो फर पुल टेस्टिङ भनेर पुल टेस्टिङको गाइडलाइन पनि एक्सेस गरेको छ। एकदमै राम्रो बनेको छ जस्तो लाग्छ मलाई। तपाईहरुले यसमा गएर चाहिँ फर्दर स्टडी पनि गर्न सक्नुहुन्छ यहाँको कन्टेक्स्टमा। यो प्रोभिन्स 1 सिचुएसन रिपोर्ट मैले भनिसके। यसरी एभ्री डे चाहिँ उनीहरुले चाहिँ होल डिटेलमा निकालिरहेको छ, सबै कुराहरु यसमा आउँछ। मैले अलिकति यो आइसोलेसन डिस्चार्ज ट्रिटमेन्टको लागि कम्पेयर गर्नको लागि आज मात्र यो पाइ चार्ट मैले बनाउन कोसिस गरेको थिएँ। नेशनल लेभलमा हेर्ने हो भने तपाईले हेर्न सक्नुहुन्छ डेथ 0.3% छ अहिले हिजोसम्मको डेट। डिस्चार्ज चाहिँ 16.9% डिस्चार्ज छ भने आइसोलेसनमा 82.8% छ। इन टर्म्स अफ आवर प्रोभिन्स डेथ 0% and we have patients under isolation only 44.3% and discharge 5.7% छ। सो दुईटा डेटा कम्पेयर गर्ने भने नेसनल लेभल र प्रोभिन्स लेभलको हामीले कम्पेयर गर्ने भने हाम्रोमा डेथ छैन, त्यो पनि एउटा राम्रै पक्ष मान्नुपर्छ। अर्को कुरा हेर्ने भने आइसोलेसनमा कम छ डिस्चार्ज भन्दा, नेसनल कन्टेक्स्टमा आइसोलेसनमा धेरै नै छ भनेपछि हाम्रो मेजर सेयर चाहिँ आइसोलेसनमा, जुन कन्ट्रीको मेजर सेयरमा हाम्रो अहिले आइसोलेसन कम छ भनेको हामीले जति कन्ट्रिब्युट गरिरहेको छौँ आइसोलेसन हाम्रो नम्बरमा चाहिँ प्रदेश एकबाट कम गरेको छ, डिस्चार्जमा चाहिँ हामी बढी छौँ भन्ने कुरा छ। यो पनि एउटा गुड साइन हो जस्तो लाग्छ मलाई। अब यसरी चाहिँ यो 14 वटा यो अलिकति केस नोटिफाइड भएछ, 14 वटा डिस्ट्रिक्ट छ प्रदेश एकमा, ओखलढुङ्गा बाहेक सबै डिस्ट्रिक्टमा केसहरू चाहिँ देखिसकेको अवस्था छ। अब यो चाहिँ हामीले गरेको काम हो। अब यसमा चाहिँ हामीले अरू पनि गाइडलाइनहरू डकुमेन्टहरू एज ए मेडिकल एक्सपर्ट ग्रुप्स वी प्रिपेयर्ड मेनी डकुमेन्ट्स, ओके, वी प्रोड्युस मेनी डकुमेन्ट्स, रिटर्न डकुमेन्ट्स, एज वेल एज we have many verbal communications. We have series of meeting with chief minister and other minister, especially for coordination between ministerial work and coordination between federal, provincial, and the local government. Another important part is the policies released by Minister of Health and Population may not be fruitful for ministers. किनभने उनीहरू उहाँहरूको चाहिँ अब अर्कै विषय परेको हुनाले चाहिँ उहाँहरूलाई त्यो पोलिसी ब्रिफहरू अथवा चाहिनु रहेछ। त्यही बेला हामीले के गर्यौँ भने जति पनि गाइडलाइन आएको छ सबैलाई हामीले स्क्यान गरेर चाहिँ हामीले उहाँहरूलाई पोलिसी ब्रिफ बनाएर प्रोभाइड गरौँ, उहाँले बुझ्ने ल्याङ्ग्वेजमा डिस्कसन गरेर, त्योले चाहिँ उहाँलाई चाहिँ धेरै हेल्प गरेको थियो। सो हामीले 20 अप्रिल 2020 मा हामीलाई फर्स्ट कन्ट्याक्ट 2 अप्रिलमा भएको थियो। विदिन 18 डेज हामीले चाहिँ कोभिड-19 योभन्दा, यो चाहिँ फाइनल रिपोर्ट हो, योभन्दा अगाडि पनि हामीले दुईटा रिपोर्टहरू चाहिँ हामीले इन्जिनियरिङ रिपोर्ट बुझाएको थियौँ, तर यो चाहिँ हामीले फाइनल रिपोर्ट चाहिँ कोभिड-19 को पेन्डेमिक प्रिपेयरनेस एन्ड कन्ट्रोल इन प्रोभिन्स नम्बर 1 प्रोभिन्स 1 चिफ मिनिस्टर इम्प्लिमेन्टेसन प्लान भनेर हामीले 20 अप्रिल 2020 मा चाहिँ बुझाएको थियो हाम्रो टिमले। यो चाहिँ हामीले ड्राइभबाट एक्सेस गर्न सकिन्छ। अब यसमा के थियो भन्ने कुरा म अलिकति भन्न चाहन्छु, त्यसपछि हामी SWOT एनालाइसिसतिर आउँछौँ। सरी, ओपन हुँदैछ अलिकति। ओके, यो चाहिँ हाम्रो वर्किङ ड्राइभ हो। यसमा मैले यो ड्राइभ किन सेयर गरिरहेको छु, यसमा हामीले चाहिँ काम गर्दाखेरि चाहिँ धेरै कामहरू गरिरहेको थियो। डाक्टर शङ्कर यही नै हुनुहुन्छ हाम्रो कोअर्डिनेटर। हामीले चिफ मिनिस्टर इम्प्लिमेन्टेसन प्लान बनाउँदाखेरि चाहिँ हामीले ट्र्याकिङको लागि अनि ट्रेसिङ ट्र्याकिङको लागि, टेस्टको लागि र ट्रिट अथवा जुन 5T को प्रिन्सिपल छ त्यो आधारमा हामीले चाहिँ सबै कुराहरूलाई चाहिँ नो के छ, ग्याप के छ, नो टु ग्याप, त्यो कुरा हामीले पत्ता लगाउन खोजेका थियौँ। इभन हामीले कस्टहरू कति छ त्यो एस्टिमेट गरेका थियौँ, पिपी को निड कति आवश्यकता छ, रिसोर्स म्यापिङहरू सबै हामीले गरेका थियौँ। अब यसमा हेर्नुहुन्छ भने जस्तो म तपाईँहरूलाई रिपोर्ट चाहिँ सेयर गरिरहेको छु। यसमा इभन हामीले चाहिँ पिपी क्यालकुलेसनहरू चाहिँ प्रोभिन्स 1 मा कसरी चाहिन्छ, कति पिपी चाहिन्छ अथवा कति टेस्ट किटहरू चाहिन्छ, कति पिसिआर गर्नुपर्छ भनेर हामीले त्यो साइन्टिफिक फर्मुलाहरू प्रयोग गरेर पनि हामीले काम चाहिँ गरेका थियौँ। त्यो सबै यहाँ गर्न गाह्रो होला। म रिपोर्ट चाहिँ अलिकति यहाँहरूलाई देखाउन चाहेँ। यो रिपोर्टमा चाहिँ हामीले के गर्यौँ भन्दाखेरि चाहिँ कोभिड-19 पेन्डेमिक प्रिभेन्सन एन्ड कन्ट्रोल इन प्रोभिन्स नम्बर 1 भनेर यो हामीले रिपोर्ट बुझाएँ। यसमा हामीले अब यो ब्याकग्राउन्ड रिपोर्ट एज ए रिपोर्ट हाम्रो अब्जेक्टिभ मेथोडोलोजी हामीले राखेका छौँ। यसमा चाहिँ हामीले मेनली सेक्सन एमा हेर्नुहुन्छ भने रिस्क क्याटेगोरी एन्ड आइटम सेलेक्सन अफ पर्सनल प्रोटेक्टिभ इक्विपमेन्ट। एक्चुअली वाट आर द डिफरेन्ट रिस्क ग्रुप एन्ड हु निड डिफरेन्ट सेट अफ पिपी भन्ने कुरा चाहिँ WHO ले पनि भन्यो, मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसनले पनि भन्यो, नेपाल मेडिकल काउन्सिलले पनि आयो। तर हामीले यसलाई एकदमै सिम्प्लिफाई गर्यौँ। हामीले यहाँ केही कुरा झिकेका पनि छौँ, केही कुरा घटाएका पनि छौँ, केही कुरा थपेका पनि छौँ र हाम्रो मिनिस्टरले बुझ्ने भाषामा अथवा चाहिँ एडमिनिस्ट्रेटरले बुझ्ने भाषामा हामीले त्यसलाई चाहिँ समाधान गर्ने कोसिस गर्यो यो डकुमेन्टमा। अब यो हाम्रो चाहिँ रिपोर्ट भएको हुनाले एकदम कन्साइज छ। हामीले कति कुरा चाहिँ रिटनमा अरू डकुमेन्ट पनि दिएका छौँ, त्यसले गर्दाखेरि यो सबै कुरा चाहिँ त्यो क्लियरली नआउन सक्ला। तर हामीले त्यसको डिस्कसनमा जस्तो हाई रिस्क हामीले चाहिँ क्याटेगोरी A B भन्दा पनि हाई रिस्क, मिडियम रिस्क र लो रिस्क भनेर भन्यौँ। अनि पिपीलाई सिङ्गल आइटम भनेर पनि हामीले छुट्यायौँ, कसलाई सर्जिकल ग्लोभ्स चाहिन्छ। अहिले पिपी भनेर चाहिँ खालि मान्छेले के बुझिरहेको छ भने कसैले पिपी भनेर सिङ्गल आइटम बुझिरहेछ, कसैले पिपी भनेर ओभरअल सेटलाई बुझिरहेछ, पिपी सेटलाई। त्यो एकदमै कन्फ्युजन थियो मिनिस्टर लेभल एडमिनिस्ट्रेटर लेभलमा। त्यही भएर हाई रिस्क, मिडियम रिस्क र लो रिस्क भन्यौँ, पिपी सिङ्गल आइटम। इभन इन्स्ट्रुमेन्टहरू आइआर थर्मोमिटरको कुराहरू पनि हामीले म्यापिङ गरेका थियौँ। त्यसपछि टेस्ट किटहरू, RDT किट त्यो बेलाको सन्दर्भमा, अब यसको धेरै कुराहरू चाहिँ डिस्कसनमै छ। मेडिसिनहरू त्यो बेला यो मेडिसिनहरू हुन सक्छ भन्ने हिसाबले ब्याकअपमा राख्नुपर्छ भन्ने कुरा, त्यो बेला टेस्टहरू अब रिसर्चहरू ट्रायलहरू अनगोइङ नै थियो। एउटा यो भयो चाहिँ कसलाई कुन प्रोभाइड गर्ने त, विच टाइप अफ पिपी सेट इज रिक्वायर्ड फर विच टाइप अफ हेल्थ केयर वर्कर्स or which type of healthcare institution, isolation hospital or level 1 hospital, level 2 hospital or level 3 hospital or non-COVID hospital त्यो गर्यौं। अर्को इन्ट्रेस्टिङ भनेको चाहिँ हामीले पिपी म्यापिङ प्रोभिन्स 1 नेपालमा भनेर हामीले चाहिँ पिपी म्यापिङ चाहिँ हामीले लेभल 1, लेभल 2, लेभल 3 जसरी गभर्नमेन्टले भनिसकेपछि हाम्रो कन्टेक्स्टमा कसरी गर्न सक्छौं त भनेर हामीले कुन कुन हस्पिटलले चाहिँ आइसोलेसन डेडिकेटेड आइसोलेसन सर्भिस दिन सक्छ भनेर हामीले म्यापिङ गरेका छौँ यो स्टेक होल्डरसँग मिटिङ गरेर। त्यसपछि हामीले जस्तो फिभर क्लिनिक पनि हाई रिस्क, मिडियम रिस्क र लो रिस्क, आइसोलेसन पनि हाई रिस्क, मिडियम रिस्क र लो रिस्क, आइसियूलाई पनि त्यसरी नै आइसियूमा चाहिँ हाई रिस्क, मिडियम रिस्क, लो रिस्क भनेर ल्याबमा पनि इभन एम्बुलेन्स ड्राइभरलाई हैन यो हामीले चाहिँ म्यापिङ गर्यौँ। प्रत्येक आइसोलेसनमा लेभल 1, लेभल 2, लेभल 3 कोभिड हस्पिटल जुन डेडिकेटेड हस्पिटल छ त्यसको लागि के चाहिन्छ हैन वी क्याल्कुलेटेड पर सिट। किनभने मन्त्रीहरूले हेर्नु हुँदाखेरि चाहिँ अथवा एडमिनिस्ट्रेटर हेर्दाखेरि चाहिँ पर सिटमा कति कस्टको उसमा पनि धेरै हेर्नुहुन्छ उहाँहरूले। पर डेको हामीले कति चाहिन्छ होला, पर विक भयो भने कति चाहिन्छ, पर मन्थ कति चाहिन्छ। अब अहिले त मन्थ पनि क्रस भइसक्यो, त्यो अनुसार हामीले चाहिँ पिपीहरूको चाहिँ म्यापिङ पनि गराएको थियौँ। यो डकुमेन्ट यहाँ क्लियरली भिजिबल छ। अब सबै कुरा यसमा चाहिँ मैले भन्न गाह्रो भयो होला। जस्तो अब हामीले एम्बुलेन्स ड्राइभरलाई पनि 2 शिफ्ट पर डे भनेर हामीले गराएको थियौँ। अनि यो पिपी किन्दाखेरि पनि एक्स्ट्रा लार्ज कति पर्सेन्ट किन्ने, लार्ज कति पर्सेन्ट, मिडियम कति पर्सेन्ट हो, स्मल साइजलाई कति पर्सेन्ट रिकमेन्डेसन गर्ने, एम्बुलेन्स ड्राइभरलाई पनि अब कसरी चाहिँ हामीले रिकमेन्ड गर्न सक्छौँ भनेर हामीले केही छलफलहरू डिस्कसनहरू गरेर चाहिँ हामीले काम गरेका थियौँ। अर्को चाहिँ अब क्याटेगोरिज अफ हस्पिटल एज पर गाइडलाइन रिलिज बाई फेडरल गभर्मेन्टलाई हामीले मोर सिम्प्लिफाई गर्ने कोसिस गरौँ। जस्तो हब हस्पिटल भनेर BJHS, कोशी जोनल र मेची जोनल हस्पिटल यहाँको कन्टेक्स्टमा भनेको थियो। प्रोभिन्सियल हस्पिटलहरू भनेर उनीहरूले म्यापिङ गरेका थियो। र अहिले चाहिँ अब प्रोभिन्सियल तपाईँको कोभिड-19 को लागि चाहिँ डेडिकेटेड सेन्टर भनेर पूर्वाञ्चल युनिभर्सिटी टिचिङ हस्पिटल जुन बोर्डगाउँमा रहेको छ पूर्वाञ्चलको प्रदेशको, त्यहाँ चाहिँ अहिले डेडिकेटेड हस्पिटलको रूपमा काम भइरहेको छ। र मेडिकल कलेजहरूमा हामीले कसरी चाहिँ काम गर्न सक्छौँ होला भन्ने हिसाबले भोलिका दिनमा अझ चाहिँ ब्रेक भइदियो भने, आउटब्रेक अझ चाहिँ भनौँ न धेरै नै हुँदै गयो भने चाहिँ हामी कसरी जान सक्छौँ, कम्युनिटी ट्रान्समिसनहरू भयो भने हामीले कसरी चाहिँ मेडिकल कलेजहरूलाई मोबिलाइज गर्न सक्छौँ भन्नेमा पनि हाम्रो केही छलफलहरू भएको थियो। र गभर्मेन्टले गरेको भने चाहिँ लेभल 1 भनेर माइल्ड केसहरूलाई राखेको छ, लेभल 2 भनेर मोडरेट र सिभियरलाई राखेको छ, लेभल 3 भनेर चाहिँ मोडरेट सिभियर विथ मल्टी स्पेसियालिटी, इफ दे निड मल्टी स्पेसियालिटी सर्भिसेस देन लेभल 3 हस्पिटल चाहिन्छ भनेर चाहिँ BJHSलाई भनेको छ। यो चाहिँ अहिले अपग्रेड भइसकेको छ। यो बाहेक हामीले अहिले पूर्वाञ्चल युनिभर्सिटी को हस्पिटलमा आएको छ, त्यसै गरी आर्मी हस्पिटलमा पनि सुगार गर्न खोजिरहेको छ, मेचीमा पनि एक्सपान्ड गर्न खोजिरहेको छ। त्यसले गर्दाखेरि चाहिँ अहिले चाहिँ आइसोलेसन हस्पिटलको सङ्ख्या पनि नम्बर पनि बढिरहेको छ र बेड पनि सङ्ख्याहरू पनि बढिरहेको अवस्था चाहिँ छ। अर्को अब इन्ट्रेस्टिङ पार्ट भनेको चाहिँ यो हुन सक्ला, जस्तो बिफोर गोइङ फर सर्ट एनालाइसिस इन द करेन्ट कन्टेक्स्ट व्हाट आर द प्लान अफ एक्सन फर कोभिड-19 पेन्डेमिक कन्ट्रोल। अहिलेको बढी टेक्निकल कुरा थियो। यसमा चाहिँ हामीले प्रिभेन्सन इन कन्ट्रोल अफ स्प्रेड अफ कोरोना भाइरस फ्रम बोर्डर, बिकज वी आर नियर बाई बोर्डर, हाम्रो तिनतिर बोर्डर छ। त्यसले गर्दाखेरि चाहिँ हामीले प्रिभेन्सन कन्ट्रोलमा के गर्न सक्छौँ भन्दाखेरि कन्ट्रोल टाइट कन्ट्रोल एट बोर्डरमा चाहिँ डिस्पाइट बोर्डरसिप देयर इज स्टिल इन्फिल्ट्रेसन अफ पिपल फ्रम इन्डिया। यो बेला चाहिँ इन्डियाबाट मान्छे ल्याउने भनेको थिएन, त्यो बेलासम्म अफिसियल डिसिजन भएको थिएन। वी निड टु आइडेन्टिफाई स्ट्रङ अल्टरनेटिभ वेज अफ फर 100% इफेक्टिभनेस, फाइन्ड अनअफिसियल च्यानल्स एन्ड सिल देम। बोर्डरबाट त आउन दिएको थिएन तर अनअफिसियल च्यानलबाट धेरै आउँथ्यो। त्यही भएर हामीले त्यही बेला चाहिँ बोर्डरको छेउमा होल्डिङ एरियाहरू बनाउनुपर्छ, क्वारेन्टाइनहरू बनाउनुपर्छ। गभर्मेन्टले जुन नेपाल गभर्मेन्टले जुन भनेको गाइडलाइन छ त्यो अनुसारै जानुपर्छ हामीले भनेर त्यो बेला नै भने। त्यसपछि सायद मिनिस्टर लेभलमा पनि यो धेरै नै छलफल भएर यस बारेमा चाहिँ पोजिटिभ कुराहरू पनि आयो। पछि चाहिँ अब जसरी चाहिँ क्वारेन्टाइनहरू बनेको थियो त्यो क्वारेन्टाइनलाई चाहिँ डेडिकेटेड क्वारेन्टाइनमा लानुपर्छ भनेर टाढीमा बनेको क्वारेन्टाइनलाई पछि पूर्वाञ्चल युनिभर्सिटीमा पनि सारिएको छ। त्यहाँ चाहिँ डेडिकेटेड क्वारेन्टाइन विथ फुल फेसिलिटी छ। त्यही भएर यहाँहरूले सुन्नुभयो होला प्रदेश 1 मा आज पनि क्वारेन्टाइनमा खासै त्यस्तो प्रब्लमहरू चाहिँ सुनिएको अवस्था छैन। चेकअप अफ एभ्री इन्डिभिजुअल हु क्रस द बोर्डर, जो बोर्डर क्रस गर्छ उसलाई टेम्परेचर मात्रै मोनिटरिङ गरेर कोरोना पत्ता लाग्दैन, उसलाई डिटेल चेकअप गर्नुपर्ने होला। अब आरडिटी गर्ने हो कि पिसिआर गर्ने, जो चाहिँ रिसोर्स भएअनुसार एक्सपर्टसँग छलफल गरेर गर्नु पर्यो भन्ने। अनि हस्पिटल आइसोलेसन विदर विदाउट टिपिकल सिम्टम अर हिस्ट्री अफ कन्ट्याक्ट विथ कोभिड-19 पोजिटिभ पर्सन अर देयर फ्यामिली मेम्बर्स एन्ड केयरटेकरमा हामीले हस्पिटल आइसोलेसनको कन्सेप्ट पनि भनेका थियौँ र होम आइसोलेसनको कन्सेप्ट पनि भनेका थियौँ। किनभने भोलि हस्पिटलमा हामी सबैलाई आइसोलेसनमा राख्न सक्दैनौँ र अहिले WHO ले भनेअनुसार एसिम्प्टोमेटिक केसेसहरूलाई पनि चाहिँ हामीले हस्पिटल भन्दा पनि होम आइसोलेसनतर्फ जानुपर्छ भन्ने कुराहरू चाहिँ आइसकेको अवस्था छ। र अर्को डेन्जर भनेको क्वारेन्टाइन म्यानेजमेन्ट। क्वारेन्टाइन भनेको चाहिँ लगेर सबैलाई हालिदिएको छ, टेम्परेचर रेकर्ड गरेको छ होइन। अब त्यो टेम्परेचर रेकर्ड पनि गर्दैन, अनि त्यहाँ तासहरू खेलिरहेको हुन्छ, सँगै खाना खाइरहेको हुन्छ भने त्यहाँ डिस्टेन्स मेन्टेन भइरहेको छैन। कतै क्वारेन्टाइनहरू चाहिँ झन् डेन्जर हुन सक्छ कि। अब हामीले टेम्परेचर रेकर्ड कसरी गर्ने, एसओएस उनीहरूले आफै एसओएसमा गर्ने अथवा ट्वाइस गर्ने, उनीहरूलाई गर्न सिकाउने हो कि मेजर गर्न उनीहरूलाई थर्मोमिटरहरू दिने हो कि अन द बेसिस अफ कम्प्लेनमा गर्ने हो कि। कोमोर्बिड कन्डिसनहरू स्पेसली डायबिटिज, हाइपरटेन्सन, आजमा अथवा हार्ट डिजिजहरू, साइकेट्रिक प्रब्लमहरू यो कन्सिडरै भएको छैन क्वारेन्टाइनमा। र मान्छेहरू मेडिसिन नपाएर अथवा अरू कोमोर्बिड कन्डिसनहरूले चाहिँ क्वारेन्टाइनमा डेथ हुने सक्ने सम्भावनालाई हामीले पहिले नै भनेको थियौँ। यो कुरा चाहिँ गभर्मेन्टले टेक केयर गरेको छ। प्रोमिस नम्बर 1 हेल्थ एजुकेसनको लागि हामीले क्वारेन्टाइनहरूमा चाहिँ भिडियोहरू बनाउने, पर्सनल हाइजिनहरू, सोसियल डिस्टेन्सिङ, योगा मेडिटेसनको भिडियोहरू बनाएर चाहिँ डेमोन्स्ट्रेट गरिदिरहने, त्यहाँ देखाइदिरहने स्क्रिनमा भनेको थियौँ, त्यो पनि इम्प्लिमेन्ट चाहिँ पुरा रूपमा भएको छैन, केही हुने कोसिसमा छ। अर्को भनेको चाहिँ अब साइकोलोजिस्टहरूले काउन्सिलरहरूले काउन्सिलिङ गर्ने पोजिटिभ थिङ्किङको कुराहरू, अब बिजनेस फ्यामिलीसँग अब इन टच नहुन पाएको होला, बिजनेस लसको कुरा होला, जब इन्सेक्युरिटी भयो, फाइनेन्सियल क्राइसिस भयो, फ्युचर कन्सिक्वेन्सेस अफ लकडाउनले जुन एउटा प्रब्लम भइरहेको हुन्छ त्यो कुरालाई कसरी चाहिँ ट्याकल गर्न सकिन्छ भनेर हामीले क्वारेन्टाइनमा बस्ने मान्छे र उसको फ्यामिलीलाई पनि हामीले चाहिँ र सराउन्डिङ कम्युनिटीलाई पनि चाहिँ एडभोकेट गर्नुपर्छ भन्ने कुराहरू गरेको थियो। त्यो त्यति राम्रो इम्प्लिमेन्ट अझै हुन सकेको छैन। अर्को चाहिँ पोसिबल इन्टरटेनिङ एक्टिभिटिज फर अ फ्यु आर टु रिड स्ट्रेस एन्ड एन्जाइटी स्ट्रेस, जस्तो डान्सहरू गराउने हामी फेसबुकतिर मिडियाहरूमा आइरहेको देख्छौँ होइन, डिस्टेन्स मेन्टेन गरेर उनीहरूको रेक्रिएसन फेसिलिटीहरू कसरी गर्ने त्यो कुरामा चाहिँ क्वारेन्टाइनमा काम भएको छैन जस्तो लाग्छ मलाई धेरै ठाउँमा। एडिक्वेट कम्फर्टेबल स्पेस एन्ड इन्भाइरोमेन्ट फर रेस्ट, स्लिप, मस्किटो नेट, फ्यान, टोइलेट, बाथरुम एन्ड एक्सर्साइज। बाथरुम र टोइलेट लाइन लागेर बस्नुपर्छ, अब त्यो टोइलेट लाइन लागेर बस्नुपर्छ, अरू डिजिज लाग्ला कि भन्ने कुराहरू पनि छ। अब मस्किटो नेटहरू यस्तो तराईको क्षेत्रमै भन्नुहुन्छ नि, मस्किटो नेट फ्यानहरू भएन भने त गर्मीले मान्छे सुत्न पनि सक्दैन। अब कोरोना भन्दा पनि नन कोरोनाको कारणले चाहिँ मान्छेको डेथ हुन सक्छ भन्ने कुरा हो। गुड मेल एन्ड सफिसियन्ट ड्रिङ्किङ वाटर, अब न्युट्रिसन, अब हाम्रो इम्युनिटी बढाउनु पर्छ, भाइरल डिजिज हो भन्ने कुरा आइरहेको छ। त्यो गर्दाखेरि यो कुराहरूमा चाहिँ त्यति ध्यान अझै पनि चाहिँ दिएको छैन कि भन्ने कुराहरू चाहिँ विभिन्न क्वारेन्टाइनमा आइरहेको छ। तर लेटर डेजहरूमा चाहिँ धेरै इम्प्रुभमेन्ट भएको छ। सो रेडियो फेसिलिटी, टिभीहरू, वाइफाईहरू दिनु पर्यो। र त्यसपछि अहिले पनि के प्रब्लम भइरहेको छ, ल्याएर क्वारेन्टाइनमा राखेको छ तर उसलाई पिसिआर गरेर घर पठाउने कि, जस्तो मैले आज प्रदेश एक महिना अरू प्रदेशमा सुनेको 30 दिन भइसक्यो त्यो आन्दोलन भइरहेको छ, 30 दिन भइसक्यो कुनै पनि टेस्ट भएको छैन, कुनै पनि डिसिजन आउँदैन, इसा निकालेर राखेको छ, प्रदेश सरकारले गर्दैन भनेपछि त्यो एकदमै चाहिँ घातक हुन सक्छ, फ्याटल हुन सक्छ। त्यो कुरालाई पनि चाहिँ गर्नुपर्छ भन्ने कुराहरू पनि आएको छ। अर्को अब एडभाइस टु बी एट होम ड्युरिङ लकडाउन अर एटलिस्ट 1 मोर विक इन क्वारेन्टाइन होइन। अब जब क्वारेन्टाइनबाट घर पठाएपछि पनि अथवा आइसोलेसनबाट घर पठाएपछि ऊ चाहिँ 14 दिन अथवा 7 देखि 14 दिन चाहिँ घर बसेको बेटर भन्ने कुरा, भिडबाट नजाने कुराहरू पनि गर्नुपर्छ भन्ने कुराहरू यो चाहिँ के हदसम्म इम्प्लिमेन्ट भएको छ। अब क्वारेन्टाइनबाट हस्पिटलहरूमा कसरी आउने, के आउने त्यो गाइडलाइन पनि हामीले दिएको, जस्तो डायबिटिज भएको मान्छेहरूलाई कसरी म्यानेज गर्ने भन्ने कुराहरू म यो सबै चाहिँ जान्न चाहिनँ। अलिकति ट्रेसिङ र टेस्टिङ अफ पिपुल हु हेभ इन्टर्ड द कन्ट्री विदाउट हेल्थ चेकअप बाई हेल्थ पर्सनल्स एट बोर्डर एन्ड नट आस्केड टु बी टेस्टेड फर कोभिड-19 छ भने हामीले कसरी गर्ने भनेर चाहिँ यो हामीले चाहिँ 1157 वार्डहरू छ प्रदेश एकमा, त्यो हामीले एउटा मेकानिजम बनाएको थियो। म सबै यो प्रोसेसमा चाहिँ जान चाहिनँ हजुरहरूलाई होइन। अर्को इफेक्टिभ लकडाउन एन्ड इट्स मोनिटरिङ, अहिलेको कन्टेक्स्टमा अब लकडाउन त खुलिसकेको छ अहिले, तर अब त्यो लकडाउन खोल्नु अगाडि चाहिँ एउटा टिम अफ फिल्ड इपिडेमियोलोजिस्टको टिम बनाएर चाहिँ त्यसले काम गर्नुपर्छ भनिहाल्यो, तर हुन सकेको छैन। र यो सिआइसिटी टिम जुन बनाएको छ त्यो पनि इफेक्टिभली फङ्सनिङ हुन सकिरहेको छैन। अब सेकेन्ड वेभ आउन सक्यो, आउने अवस्था आयो भने चाहिँ कसरी रोक्ने, अहिले लकडाउन खोलेको छ, भोलिका दिनमा फेरि महामारी लोकल कन्टेक्स्टमा फैल्यो भने के गर्ने भन्ने कुरामा चाहिँ अझै पनि काम हुन सकिरहेको अवस्था छैन। अहिले चाहिँ हामी खालि बाहिरबाट आएकोमा बढी फोकस भइरहेका छौँ। अनि अब यो मिल्क, भेजिटेबल, फ्रुट्स, मेडिसिन दिने कुराहरूमा पनि छ। अब अर्को फ्रिक्वेन्ट मोटिभेसनल स्पिच एन्ड इन्स्ट्रक्सन बाई हायर अथोरिटी टु पब्लिक, जस्तो मुख्यमन्त्रीले अथवा मिनिस्टरहरूले अथवा कन्सर्न पर्सनहरूले आफ्नो जनताहरूलाई चाहिँ अलिकति भनौँ न एस्योर गर्नु पर्यो क्या। र यो कुरा आइसकेपछि मुख्यमन्त्रीले प्रदेशमा चाहिँ अब अल्टरनेट डेमा चाहिँ के गर्नुहुन्छ भने समय मिलाएर चाहिँ उहाँले चाहिँ अहिले चाहिँ पब्लिकले चाहिँ फेसबुक मार्फत अथवा टेलिभिजन मार्फतबाट चाहिँ एड्रेस गरिरहनु भएको छ। जस्तो अब बेटर आइसोलेसनको कुराहरू भयो, ट्याक्सको कुराहरू भयो, रिलिफको कुराहरू भयो, जब सेक्युरिटीको कुराहरूमा के कुराहरू चाहिँ डेफिनेटली भइरहेको अवस्था छ। र हामीले त्यसरी नै आइसोलेसन र प्रोपर मेडिकल म्यानेजमेन्टमा पनि पोजिटिभ केसेसहरूलाई कसरी म्यानेज गर्ने भन्ने कुराहरू गरेका थियौँ। म यो जान्न चाहिनँ सबै रिपोर्टमा। सिम्प्टोमेटिक पेसेन्टलाई कसरी म्यानेज गर्ने, प्रोफाइलेक्टिभ ट्रिटमेन्टको कुराहरूमा हाम्रो साइन्टिफिक इभिडेन्स त्यसमा कसरी जाने, डब्ल्युएचओको प्रोटोकललाई कसरी जाने। र अर्को भनेको चाहिँ हस्पिटलबाट डिस्चार्ज भएको पेसेन्टलाई अथवा केसहरूलाई चाहिँ कसरी मोनिटरिङ गर्ने लोकल सेटिङमा, त्यो चाहिँ एकदमै महत्त्वपूर्ण कुरा छ। त्यसमा पनि हामीले केही कुराहरू चाहिँ भनेका थियौँ। अर्को चाहिँ अब रिहेबिलिटेसन, अहिलेको सबभन्दा च्यालेन्ज भनेको कोभिड-19 हस्पिटलबाट उपचार भएर घर गइसकेको मान्छेलाई सोसाइटीले अझै एक्सेप्ट गरिरहेको छैन। त्यो चाहिँ एकदम च्यालेन्ज छ। त्यसको लागि चाहिँ हामीले कसरी चाहिँ कुन मेकानिजममा जानुपर्छ भनेर हाम्रो चाहिँ अहिले छलफल पनि भइरहेको छ। र बायोसेफ्टी र हस्पिटल वेस्ट म्यानेजमेन्टमा अहिले इस्युजहरू आइरहेको छ। पुरानो हस्पिटलबाट आएको जुन हेल्थ केयर वेस्टहरू चाहिँ राम्रो डिस्पोज भएन भन्ने धेरै इस्युजहरू आइरहेको छ। अर्को मास सेनिटाइजेसन गर्ने कुराहरू चाहिँ कतिको साइन्टिफिक छ त्यो कुराहरू, डेड बडी म्यानेजमेन्टको कुराहरू पनि फेडरल गभर्मेन्टबाट चाहिँ भएको गाइडलाइन अनुसार कामहरू भइरहेको छ। यो भयो। अर्को चाहिँ हामीले गरेको भनेको मेडिसिनहरू कति चाहिन्छ कोरोना हस्पिटललाई भनेर पनि एउटा म्यापिङ गरेको थियो होइन, टेन्टेटिभली। म सबै जान्न चाहिनँ। आइसियु वार्डलाई कति चाहिन्छ होइन, कन्ज्युमेबलहरू, अरू सपोर्टहरू, भेन्टिलेटर सर्किटको कुराहरू छ त्यो कति चाहिन्छ भन्ने कुराहरू भयो। त्यसरी अब कोभिड हस्पिटल जुन इस्टाब्लिस भयो, जुन दिन केस आयो एकैचोटि, त्यो अघिल्लो दिन हामीले चाहिँ त्यहाँनेरि डिफिब्रिलेटर कतिवटा चाहिएला, टिभी कतिवटा चाहिएला, पेसेन्टको बेड साइड माइक सिस्टम कति चाहिएला हैन, यो सबै कुराहरू चाहिँ हामीले गरेका थियौँ। विन्डो नेटहरू कतिवटा छ, इभन त्यहाँ हामी जाँदाखेरि कोभिड हस्पिटल जुन बिराटमा सुरु भयो त्यहाँ विन्डो नेट थिएन। भोलिपल्ट बिरामी अघिल्लो दिन हामी पुग्दाखेरि विन्डो नेट थिएन। गरे एकदमै राम्रो गरे गभर्मेन्टले, तर त्यो छुटेको हो क्या, नजानेको होइन, त्यो छुटेको काम गर्दा गर्दै त्यो दिन हामीले विन्डो नेट भने विन्डो नेट आयो, नत्र भने त अब त्यहाँ त डेङ्गु र मलेरियाले नै लाग्न सक्ने सम्भावना भयो। कोरोना भन्दा डेङ्गु मलेरिया लाग्न सक्ने भयो। त्यो कुराहरूले पनि त्यहाँ विरोध हुन सक्थ्यो। इभन अब कतिपय कुराहरू जस्तो आर्टिफिसियल लङका कुराहरू, यो टेस्टिङका कुराहरूमा हामीले चाहिँ स्पेसली भेन्टिलेटर सपोर्टका कुराहरू पनि गरेका थियौँ। विन्डो नेट चाहिँ एउटा तुरन्त गर्न सक्ने कुरा थियो, त्यो हामीले गऱ्यौँ। वाइफाई राउटरको कुराहरू भयो। अब अर्को भनेको कलेक्सन अफ डाटा फ्रम इच वार्ड। हामीले दिएको सजेसन र गर्नुपर्ने कुरा के हो भने चाहिँ कतिजना विदेशबाट आए त्यस अझै पनि त्यो कन्ट्याक्ट जुन फरेन रिटर्निजहरूको अथवा फरेन भनेको खालि थर्ड कन्ट्री मात्रै हो नि, इन्डियाबाट आएको मान्छे अफिसियल अनअफिसियल च्यानल, त्यो चाहिँ अझै पनि त्यो डेटाहरू चाहिँ कलेक्सन भएको छ, तर त्यो पब्लिक एभाइलेबल भएको छैन क्या। अब त्यसलाई एनोनिमस गरेर गर्नुपर्ने हो कि अथवा त्यसलाई अझै फाइनल सेपमा ल्याउन सकिरहेको अवस्था छैन। जस्तो होम क्वारेन्टाइन आइसोलेसनको कुराहरूमा कोही मान्छे घरमा अब आइसोलेसन, अहिले सेल्फ आइसोलेसनमा बस्नु भनेको छ, सेल्फ क्वारेन्टाइनमा बस्नु भनेर गाइडलाइन आएको छ, तर त्यसलाई मोनिटरिङ गर्ने च्यानल के हो त, कसले मोनिटरिङ गर्ने, को एक्सपर्टले सुझाव दिने, त्यो कुराहरू एकदम ल्यागिङ छ, स्पेसली यो चाहिँ लोकल गभर्मेन्ट सेटिङहरूमा होइन। र हामीले अर्को भनेको चाहिँ जस्तो यो प्र्याक्टिकल गाइडलाइन फर टेस्टिङ, आरडिटी पिसिआर क्वारेन्टाइन आइसोलेसन ट्रिटमेन्टमा बसेकोहरूलाई, क्वारेन्टाइनको आइसोलेसन जुन ट्रिटमेन्टमा बसेकोहरूलाई चाहिँ कुन बेला आरडिटी गर्ने, कुन बेला पिसिआर गर्ने भनेर हामीले धेरैसँग छलफल गरेर बनाएको छ यो गाइडलाइन होइन। अब यो कुरा आजको कन्टेक्स्टमा अलिकति एप्लिकेबल नहुन सक्छ, तर त्यो कन्टेक्स्टमा हामीले मुख्यमन्त्रीले बुझ्ने भाषामा, मिनिस्टरले बुझ्ने भाषामा बुझाएर बनाएको छ। त्यसपछि आएर हामीले अब जस्तो क्वारेन्टाइन आइसोलेसनको कुराहरू होइन, होम आइसोलेसनको कन्सेप्ट जस्तो यो अहिले फेडरल गभर्मेन्टले ल्याउनु अगाडि नै हामीले लोकल डिस्कसन त भएको थियो होला, डाक्टर शङ्कर यही हुनुहुन्छ, हामीले धेरैचोटि होम आइसोलेसन र डेडिकेटेड होम आइसोलेसनको कुरा गरेका थियौँ, जुन आज ओके भइसकेको अवस्था छ। यो कुरा हामीले गभर्मेन्टलाई चाहिँ अप्रिल 20 मै दिएको थियौँ। सरी, अनि अर्को हस्पिटलाइजेसन कन्डिसन माइल्ड केसलाई के गर्ने, कोमोर्बिडिटिजहरूलाई जस्तो कोभिड-19 हस्पिटलमा अहिले आइसोलेसन क्वारेन्टाइनमा राखिदिएको छ, हाइपरटेन्सनको बिरामी छ, उसलाई अब त्यहाँ डक्टर छैन भने त हाइपरटेन्सनको औषधि नखाएर मान्छे मर्न सक्छ, डायबिटिजको मर्न, सर्पले डसेर मान्छे मरिरहेछ। त्यो कुराहरू पनि धेरै ध्यान दिनु पर्यो भन्ने कुराहरू चाहिँ अब अहिलेको कन्टेक्स्टमा चाहिँ आइरहेको अवस्था छ। यो चाहिँ हाम्रो अब स्न्यापसटहरू डिफ्रेन्ट प्रोग्रामको, म यतातिर जान चाहिनँ। अब म हजुरहरूलाई अलिकति, मेरो समय पनि सकिन आँटो होला, यो फोरमबाट एक्सपेक्टिङ सोल्युसन है, अब डिस्कसन त ठिक छ, तर सोल्युसन चाहिँ के आइदियो भने चाहिँ भोलिका दिन प्रोभिन्स गभर्मेन्टलाई केही हेल्प हुन्छ भनेर हाम्रो टिमले चाहिँ हामीले एक्सपेक्ट पनि गरेका छौँ। SWOT एनालाइसिस हामीले स्ट्रेन्थ, विकनेस, अपर्च्युनिटी, थ्रेट भनेर 4वटा छ यो SWOT एनालाइसिस, हामी सबैले जानेकै कुरा हो। यसमा चाहिँ म डाक्टर प्रजुलाई पनि धन्यवाद दिन चाहन्छु, डाक्टर शङ्कर हुनुहुन्छ, टिमलाई धन्यवाद दिन चाहन्छु, धेरै साथीहरूले हेल्प पनि गर्नुभएको छ। हामीले छलफल गरिरहेका छौँ। एक्चुअली हामीले 60मा चाहिँ ट्रेसिङ ट्र्याकिङदेखि लिएर जुन टेस्ट छ, त्यो 60 जुन छ, त्यो 60मा नै हामीले SWOT एनालाइसिस गरिरहेका छौँ र यो चाहिँ अहिले हामी ओभरअलको हामी म प्रेजेन्ट गर्न गइरहेको छु। हामीले स्ट्रेन्थहरू हामीले के पत्ता लगायौँ प्रोभिन्स नम्बर 1 को भने टाइमली इस्टाब्लिसमेन्ट अफ डेडिकेटेड कोभिड-19 हस्पिटल, जुन हाम्रो नेसनल ट्रेनिङ थियो बिराटनगरमा, डाक्टर शङ्करकै अग्रसरतामा त्यो भएको हो। त्यो बेला चाहिँ टाइमली इस्टाब्लिसमेन्ट अफ डेडिकेटेड कोभिड-19 हस्पिटल, त्यो बेलामा काठमाडौँमा थियो, डाक्टर शङ्करहरू यहाँ हुनुहुन्थ्यो, धेरै छलफल भएको थियो त्योभन्दा अगाडि पनि हामी डेडिकेटेड हस्पिटल। इभन सेन्ट्रल गभर्मेन्टले गर्नुभन्दा अगाडि नै प्रदेश 1 सरकारले यो बनाएको थियो, त्यसले गर्दाखेरि चाहिँ प्रदेश 1मा त्यति आत्तिनुपर्ने अवस्था आएन। भोलिपल्ट 12वटा केस आयो, आए पनि प्रदेश सरकार आनन्दले त्यसलाई म्यानेज गरिरहेको अवस्थामा थियो, आत्तिने अवस्थामा नि थिएन। त्यसले गर्दाखेरि लेभल 1, लेभल 2, लेभल 3 को कन्सेप्ट प्रदेश 1 सरकारले राम्रै बुझेछ जस्तो लाग्छ मलाई। त्यो अनुसार काम भइरहेको छ, अहिले धेरै नै त्यो अनुसारको इम्प्लिमेन्ट भइसक्यो। तपाईँ प्रदेश नम्बर 2 सँग हामी कम्पेयर गर्ने हो भने हामी अहिले कम्पेयर गर्ने स्टाटसमा छैनौँ, धेरै इम्प्रुभमेन्ट छ। इभन प्रदेश 1 को चाहिँ सामाजिक विकास मन्त्रीले प्रदेश 2 लाई पनि हामी ब्याकअप दिन सक्छौँ भन्नुभएको छ। यो भनेको उहाँको स्ट्रेन्थ, कन्फिडेन्स हो। फाइनेन्सियल सेक्युरिटी फर अल फ्रन्टलाइनर्स, केही दिन अगाडि गभर्मेन्टले भन्यो, सेन्ट्रल गभर्मेन्टले 25 लाख गर्छौँ भनेर हामीले के भन्यो, हामीले 1 करोड दिनुपर्छ भनेको थियौँ। जसलाई फ्रन्टलाइनर्स, त्यो डक्टर पनि हुनसक्छ, नर्स, जोसुकै हो, स्वास्थ्यकर्मी, सञ्चारकर्मी अथवा स्वास्थ्य सुरक्षाकर्मी, फ्रन्टलाइनरमा हुन्छ र उसको डेथ कोरोना कारणले भएको छ भने वी हेभ टु फाइनेन्सियली सेक्योर्ड गर्नु पर्यो। 1 करोड भनेको थियौँ। भोलि पर्सिपल्ट मन्त्री परिषदको मिटिङ बसेर 50 लाख आयो र प्रदेश 1 फर्स्ट भएको यो कुरामा। त्यसपछि पिसिआर स्टार्टेड एट BBKHS, BBKHS आशयमा एउटा रिनाउन्ड सेन्टर पनि भएको, हामीले भ्यालीभन्दा बाहिर चाहिँ BBKHS सुरु भयो, जुन चाहिँ हाम्रो राम्रो एसेट भयो। हामीले त्यसपछि अहिले त अब पिसिआरहरू धेरै ठाउँमा हुन थालिसक्यो। आइसोलेसन स्ट्रेन्थिङ क्यापेसिटिज, प्रदेश नम्बर 1 मा धेरै मेनी हेल्थ केयर इन्स्टिट्युसन छ विदिन प्रोभिन्स, मेडिकल कलेज छ, हस्पिटलहरू छ। त्यसले गर्दाखेरि आइसोलेसनलाई हामीले अझै स्ट्रेन्थिङ गर्ने हामीसँग क्यापेसिटी छ। भोलिका दिनमा आयो भने अफिनले प्राइभेट मेडिकल इन्स्टिट्युसन संस्थाहरू छ, हामीले चाहिँ आइसोलेसनलाई स्ट्रेन्थिङ गर्न हामीसँग क्यापासिटी छ, हामीसँग ब्याकअप छ। मल्टिडिसिप्लिनरी हेल्थ वर्कर छ, हामीसँग पब्लिक हेल्थ नर्सिङदेखि लिएर एक्सपर्टहरू सबै एक्सपर्टहरू यो प्रदेशमा छ, त्यसलाई गभर्मेन्टले युज गर्न सक्छ। अर्को भनेको रेस्पोन्सिबल मिडिया, किन भन्दाखेरि यहाँ डेडिकेटेड कोरोना इन्फर्मेसन डेस्क चिफ मिनिस्टर अफिसमा छ र प्रत्येक दिन त्यसको अपडेटहरू हुन्छ। त्यसमा हामीले पनि धेरै कामहरू गरेका छौँ। जस्तो मिडिया चाहिँ ह्युमर कन्ट्रोल चाहिँ एकदमै महत्त्वपूर्ण कुरा हुन्छ, राष्ट्रको चौथो अङ्ग हो भनेपछि गर्नुपर्छ भन्ने कुरामा चाहिँ एकदमै लागेको। म आफै प्रोग्राम रेडियो प्रोग्राम चलाउने भएको भएर पनि यस कुरामा चाहिँ म एकदमै सचेत पनि थिएँ र हामीले धेरै कुराहरू गरेका छौँ यसमा चाहिँ। अर्को बेटर सोसल कन्स्ट्रक्टर हो, हाम्रो प्रदेशको हेऱ्यो भने लिटरेसी र सोसियल स्ट्याटस पनि समहाउ बेटर छ, त्यो पनि हाम्रो लागि एउटा स्ट्रेन्थ हुन सक्छ। इजी एक्सेसिबिलिटी फर ट्रान्सपोर्टेसन एक्सेसिबिलिटी पनि भएको हुनाले हाम्रो स्ट्रेन्थ देखियो। गुड फिजिकल इन्फ्रास्ट्रक्चर, आइसोलेसनमा हामी लेभल 1 को लागि होटेलहरूलाई, ट्रेनिङ सेन्टर, मलहरूलाई पनि हामी प्रयोग गर्न सक्छौँ भोलिका दिनमा, त्यसको लागि हामीसँग ब्याकअप प्लानहरू छ। प्रोभिन्स वान स्पेसिफिक गाइडलाइन इन पोलिसी जुन बनाए प्रदेश एकले, त्यो एकदमै अर्को एसेट रहेको छ। यो चाहिँ हाम्रो स्ट्रेन्थको रूपमा के पोइन्टहरू हामीले राखेका छौँ, यसमा कुनै विकनेस कुनै अपर्च्युनिटीतिर पनि सो गर्न सक्ला, तर केही स्ट्रेन्थ हो भन्ने कुरा चाहिँ हामीले यसमा राखेका छौँ। अब विकनेस डेफिनेटली जहिले पनि स्ट्रेन्थ र विकनेस धेरै देखिन्छ। अब विकनेसमा चाहिँ हाम्रो एक्सपर्टाइज मिसम्यापिङ, हामीसँग धेरै समय थियो प्रदेश एकमा कोरोना आउनुभन्दा अगाडि अथवा नेपालमा कोरोना कोभिड-19 देखिनुभन्दा अगाडि हामीसँग धेरै टाइम थियो। त्यो बेला प्रदेश सरकार कहाँ चुक्यो भन्दाखेरि हस्पिटल बनाउनुतिर लाग्यो, तर यो चाहिँ हस्पिटलमा ट्रिटमेन्ट गर्ने भन्दा पनि हस्पिटल बाहिर हो भन्ने कुरामा ध्यान चाहिँ अलिकति नपुगेर एक्सपर्टिजहरूको मिसम्यापिङ भयो क्या। एक्सपर्टिजहरू कहाँ छन् के छन् भनेर त्यसको चाहिँ पुल बनाउने काम भएन। ल्याक अफ कोअर्डिनेसन विदिन मिनिस्ट्रिज, फेडरल र लोकलसँग प्रदेशको मिनिस्ट्रीको त्यति राम्रो खालको भनौँ एउटा कोअर्डिनेसन सुरुका दिनमा थिएन, अहिले त राम्रो छ। पब्लिक प्राइभेट पार्टनरसिप पनि पुअर छ, पब्लिक र प्राइभेट पनि धेरै ग्यापहरू बनाइयो। ल्याक अफ प्रोफेसनल लिडरसिप, जुन लिडरसिप प्रोफेसनल एक्सपर्टहरूले गर्नुपर्ने त्यो भएन, नन प्रोफेसनल मान्छेहरूले लिडरसिप गरिरहेको अवस्था छ, अहिले पनि छ त्यसमा। फेलो टु किप रेकर्ड अफ फरेन रिटर्निज, त्यो एकदमै गाह्रो। फरेन रिटर्निज किनभने क्रस बोर्डर थियो, त्यो काम गर्न सकेन। इनएडिक्वेट इन्फर्मेसन अन एम्बुलेन्स सर्भिस, एम्बुलेन्स कहाँ छ, के छ, कता छ भन्ने कुराहरूमा कस्तो खालको एम्बुलेन्सको क्राइटेरिया छ, डेडिकेटेड एम्बुलेन्स कसरी त्यसलाई मोडिफाई गर्नुपर्छ होला, त्यो कुराहरूमा त्यति सुरुमा ध्यान दिएको अवस्था थिएन। फेलो टु मोबिलाइज डेडिकेटेड एम्बुलेन्स सर्भिसेस, जस्तो ल्याक अफ पिपी हुने, कहिलेकाहीँ अब ट्रान्सफर नगरिदिने होइन, ट्रान्सफर मेकानिजम प्रोटोकल के हो, त्यो कुराहरूले पनि गाह्रो पारेको थियो। पोलिसी भए पनि लोकल कन्टेक्स्टमा अथवा प्रोभिन्सियल कन्टेक्स्टमा इम्प्लिमेन्ट हुन सकेन। ल्याक अफ इन्स्टिट्युसनल कोअर्डिनेसन फ्रम साइट टु आइसोलेसन सेन्टर, अस्ति पनि सुन्नुभयो झापाको केचना कलनबाट बिपी कोइराला स्वास्थ्य विज्ञान प्रतिष्ठान ल्याउँदाखेरि मान्छे 12 घण्टा बाहिर बस्नु पर्यो भनेको, त्यहाँनिर चाहिँ लोकल गभर्मेन्टले इन्फर्मै गरेको छैन क्या, त्यसै बिरामीलाई ल्याएर बाहिर राखेको छ। अब त्यहाँ ठुलो कुरा के छ भन्दाखेरि राख्यो हस्पिटलमा त 12 घण्टापछि छिरायो, मान्छेले दुःख त पायो, तर उनीहरूले दिशा पिसाब त अवश्य गर्यो त्यही चौरीमा, त्यो कसले टेक केयर गर्ने, त्यो ठुलो इस्युज हो क्या। त्यस्तो कुरा हामीले खेलाँची गर्न अवश्य हुँदैन। अर्को भनेको चाहिँ पुअर मोनिटरिङ अफ होम क्वारेन्टाइन, होम क्वारेन्टाइन हामी भन्छौँ, होम आइसोलेसन भनेर आज कसले मोनिटरिङ गर्ने? हाम्रो हेल्थ सेन्टरहरू अथवा हेल्थ कोअर्डिनेसन अफिसहरू स्थानीय निकायमा त्यो क्यापेबल छैन, त्यो एकदमै प्रब्लम छ। विक इम्प्लिमेन्टेसन अफ क्वारेन्टाइन गाइडलाइन अफ मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसन, यो छ गाइडलाइन तर रियल इम्प्लिमेन्टेसन भएन। त्यसैले यहाँको सामाजिक विकास मन्त्रीज्यूले अस्ति पनि भन्नुभएको छ, अब चाहिँ हामीले प्रदेश एकमा चाहिँ डेडिकेटेड क्वारेन्टाइन बाहेक सबैलाई बन्द गर्ने भनेर यो मिसनमा उहाँ लागिसक्नु भएको छ। त्यो पनि एउटा राम्रो कुरा, विकनेस हुँदाहुँदै अब राम्रो कुरामा हामी आउन सक्छौँ। अर्को चाहिँ इनएडिक्वेट मोबिलाइजेसन अफ हेल्थ रिलेटेड एक्सपर्टिज के, अलिकति अननेसेसरी पोलिटिकल इन्फिल्ट्रेसनहरू चाहिँ सुरुमा भएको। यो अरू बाढी पहिरो जाँदा रात बाँडो भने भोलि बजेट आउँछ, भोलि चाहिँ भोट धेरै आउँछ भन्ने भएको, तर अहिले त्यो कुरा छैन, सबैले बुझिसक्नु भएको छ। क्वारेन्टाइन र आइसोलेसनमा मेन्टल हेल्थ चेकअप, अबको कन्डिसनमा क्वारेन्टाइन आइसोलेसन मात्रै होइन, डिपेन्डेन्ट फ्यामिली सबैलाई चाहिँ मेन्टल हेल्थ चेकअप चाहिँ एकदमै गाह्रो छ, नत्र भने सुसाइडका कुराहरू देखिरहनु भएको छ, इकोनोमिक क्राइसिसहरू भइरहेछ। खालि हामी हेल्थको पर्सपेक्टिभमा मात्रै हेर्नु हुँदैन, बियोन्ड द हेल्थको। अब सबैले जब लस गर्ने अवस्थाहरू छ, स्यालेरी लस गरिरहेछ, त्यो बेलामा चाहिँ गभर्मेन्टले के न के प्लान ल्याउनुपर्छ, यो एकदम विकनेस भइरहेछ। विक बायोसेफ्टी अफ हेल्थ केयर वेस्ट, खोलामा फाल्ने जुन हाम्रो प्रवृत्ति थियो हस्पिटलबाट, त्यो आज पनि छ, त्यो कुरालाई चाहिँ हामीले रोक्नुपर्छ। अपर्च्युनिटिज के छ त? कोरोना हाम्रो लागि खालि विकनेस मात्रै होइन, हाम्रो लागि अपर्च्युनिटी पनि बनेर आएको छ। अब हामीलाई एउटा त्यो एउटा मैले एउटा कन्टेक्स्टमा कुरा गरेँ। अब हाम्रो यो कन्टेक्स्टमा हेर्ने हो भने चाहिँ अटोनोमी टु एप्लाई स्ट्रङ लकडाउन मेजर्स, अहिले प्रदेशहरूसँग अटोनोमी छ, स्थानीय सरकारसँग अटोनोमी छ, तिनीहरू आफै सरकार हो, आफै छुट्टै गभर्मेन्ट छ भनेपछि तिनीहरूले लकडाउन मेजरलाई लुज डाउनमा कुन बेला लाने, कुन बेला कुन मेजर एप्लाई गर्ने भन्ने उनीहरूसँग अटोनोमी छ, तर त्यो अटोनोमी राम्ररी प्रयोग गर्न सकेको देखिँदैन। एडिक्वेट टाइम फर रेडिनेस एन्ड प्रिपेयर्डनेस थियो, त्यो हामीसँग एउटा अपर्च्युनिटी थियो, त्यो अपर्च्युनिटीलाई हामीले अझै क्याच गर्न सक्दैनौँ। त्यो हाम्रो लागि स्टिल अझै पनि हाम्रो लागि अपर्च्युनिटी छ, किनभने कम्युनिटी ट्रान्समिसनमा हामी गइसकेको अवस्था छैन। एडिक्वेट क्वालिफाइड लोकल हेल्थ एक्सपर्ट, हामीसँग यति धेरै मेडिकल कलेज र फ्याकल्टिजहरू छ, उहाँहरूले युटिलाइज गर्न सकेको छैन। जस्तो कर्णाली स्वास्थ्य विज्ञान प्रतिष्ठानले कर्णाली प्रदेशमा एकदमै राम्रो काम गरेको छ, ट्रिटमेन्ट गर्नेलाई ट्रिटमेन्ट राखेको छ, डायग्नोस्टिकलाई डायग्नोस्टिक राखेको छ, अरू फ्याकल्टीहरूलाई चाहिँ विभिन्न गाउँहरूमा 2-2 जना गएर पठाएको छ, इभन प्रोफेसरहरू हिँडेर जानु भएको छ। तर यहाँ हाम्रो बीपी कोइराला स्वास्थ्य विज्ञान प्रतिष्ठान अरू मेडिकल कलेजमा चाहिँ त्यो इम्प्लिमेन्ट गर्न गभर्नमेन्ट फेलर भएकै हो कम्युनिटी सेटअपमा। किनभने हामी कन्ट्याक्ट ट्रेसिङ बिना कन्ट्याक्ट ट्रेसिङ र कन्ट्र्याक्ट को लागि चाहिँ एकदम काम राम्रो हुन सकिरहेको अवस्था छैन। त्यो कुरालाई इम्प्रुभ गर्न सकिनेछ, तर अहिले चाहिँ धेरै सुधार भएको अवस्था छ है। फेरि अर्को इम्प्लिमेन्टेसन अफ सक्सेस एन्ड फेलर स्ट्राटेजिज लर्निङ फ्रम ग्लोबल सेटिङ। हामीसँग ग्लोबल सेटिङमा कहाँ के कुरा राम्रो के कुरा नराम्रो भनेर सबै थाहा थियो, तर त्यो कुराले इम्प्लिमेन्टेसन गर्न अलिकति ढिलो भएको। नत्र भने आज नेपालमा हामी यति अवस्थामा हामी आउँदैन थियो जस्तो लाग्छ। हामीले इन्डियाको बोर्डरलाई हामीले सुरुमा भने पनि थियो, पोरस बोर्डरलाई कन्ट्रोल गर्न सकेको र बोर्डरको छेउमा चाहिँ हामीले आइसोलेटेड ठाउँ राख्न सकेको भए अथवा होल्डिङ सेन्टर क्वारेन्टाइन राम्रो बनाउन सकेको भए आज यो दिन आउँदैन थियो, अवश्य इन्फिल्ट्रेसन हुँदैन थियो। मेडिकल कलेज र प्राइभेट हेल्थ केयर इन्स्टिट्युसन मल्टी स्पेसिलिटी मल्टी डाइमेन्सनल छ, हामीसँग त्यो हाम्रो लागि एउटा अपर्च्युनिटी ग्रुपमा रहेको छ। हेल्थ पोस्ट पिएससीमा यति धेरै स्टाफ छ, एफसीएचबीहरू छ, त्यसमा हामीले चाहिँ यो कम्बी एप्रोचलाई युटिलाइज गर्न सक्छौँ। कम्युनिकेसन फर बिहेभियरल इम्प्याक्टलाई हामीले गर्न सक्छौँ। त्यसको लागि त्यसका एक्सपर्टहरू हामीसँग प्रदेशमा छन्। बीसीसी बिहेभियरल चेन्ज कम्युनिकेसन, एक्टिभ सर्भिलेन्स, अवेरनेस, डाटा किपिङमा हामीले यही बजेटमा भएको एक्जिस्टिङ म्यान पावरलाई पब्लिक र प्राइभेट मिलाएर हामी काम गर्न सक्ने अवस्था रहन्छौँ। त्यो अलिकति अझै पनि विकनेस छ। अलिकति कस्तो छ भन्दाखेरि चाहिँ ग्याप छ, मान्छेले आफूप्रति ट्रस्ट भइरहेको छैन। गभर्नमेन्टलाई प्राइभेटप्रति ट्रस्ट छैन, प्राइभेटलाई गभर्नमेन्टप्रति ट्रस्ट छैन। त्यो कोभिड त्यो पेन्डेमिकमा पनि हाम्रो ट्रस्ट गेन छैन भने भोलि कहिले पनि कुनै पनि इभेन्टमा ट्रस्ट हुन सक्दैन। यो चाहिँ एउटा यसलाई चाहिँ हामीले अपर्च्युनिटीको रूपमा लिएर जानुपर्छ होला। अर्को हामीसँग डिफ्रेन्ट स्टार होटलहरू अब छ, राम्रै होटलहरू छ प्रोभिजनमा, त्यसलाई हामी भोलिका दिनमा होटल क्वारेन्टाइनमा अथवा इभन आइसोलेसनमा पनि हामी लान सक्छौँ। र थ्रेटहरू चाहिँ डाक्टर शङ्करले धेरैचोटि भन्ने कुरा र हामीले लेखेको जुन घर घरमा जुन भेजिटेबलहरू आइरहेछ, फुडहरू आइरहेछ, डेली कन्ज्युमेबलहरू आइरहेछ, को मान्छेले ल्याउँछ थाहा छैन। सपोज हाम्रो घरमा त डेलिभरी गरिरहेछ, तर त्यो मान्छेको रेकर्ड छैन। सपोज उसलाई कोरोना पोजिटिभ भइदियो त्यो मान्छेलाई भने उसले कुन ठाउँमा बेचेको छ, कसलाई सारो भन्ने कुरा त थाहा छैन। त्यो खोइ त त्यसको रेकर्डिङ, त्यो रेकर्डिङ सिम्पल तरिकाले गर्न सकिन्थ्यो होला नि त वार्ड लेभलमा, त्यो गरेको छैन। त्यो अझै पनि गरेको छ। एटिएम मेसिनमा म पैसा झिक्न गए पनि त्यहाँ सेनिटेसन मेकानिजमहरू छैन। त्यहाँ जस्तो ह्यान्ड वासहरू राखिदिएको छैन। मैले 1-2 जना ब्याङ्कसँग कुरा पनि गरेँ, राखिदिए डाक्टर साहब, तर के भयो भने चोर लग्दै भन्यो। अब हामी नेपालीहरू अब अझै पनि माइन्ड सेटअपमा अझै पनि रहेछौँ। मैले ब्याङ्कहरूमा पनि फोन गरेको थिएँ कुरामा। ओपन डिपार्टमेन्ट स्टोर, सानसानो पसल चाहिँ गाउँको सानसानो पसल चाहिँ बन्द गराएको छ, तर ठुल्ठुलो डिपार्टमेन्ट स्टोर खोलिएको छ। ल्याक अफ सोसियल डिस्टेन्सिङ, ल्याक अफ सेनिटेसन र सोसियल डिस्टेन्सिङमा प्रब्लम छ। हामीले नबुझेको होइन, नलेज छ, सब मान्छेलाई थाहा छ। तिनै रिङटोन सुनेको छ हाम्रो एनटिसी एनसेलको, तर पनि मान्छेले सोसियल डिस्टेन्सिङ मेजर गरेका छन्। यसको लागि हामीले कम्बी एप्रोच गरेर चाहिँ इम्प्रुभमेन्ट गर्नुपर्छ। लोकल हाट बजार क्राउड हिजोदेखि सुरु भइसक्यो, अस्तिदेखि यहाँ त्यसरी ओपन र पोरसबाट अझै पनि मान्छेहरू आइरहेको छ। ओपन पोरसबाट अझै पनि आइरहेको छ। त्यो कुरालाई एउटा थ्रेटको रूपमा रहेको छ। रङ प्रोसेस अफ डिस्ट्रिब्युसन अफ ह्युमेनिटेरियन मेटेरियल्स एट द टाइम अफ क्राइसिस। ह्युमेनिटेरियन मेटेरियलहरू एकदमै रङ डिस्ट्रिब्युसन भएको छ पोलिटिकल एजेन्डाले सुरुमा। अहिले केही चेन्जेसहरू भएको छ। इनएप्रोप्रिएट वे अफ फुड डिस्ट्रिब्युसन फर होमलेस एन्ड स्ट्रिट चाइल्ड, भिडभाड गर्ने, त्यहीँ बाँड्ने, फोटो खिच्ने, फेसबुक हाल्ने, त्यो कामहरू भएको छ, अहिले पनि भइरहेको छ। त्यसमा चाहिँ डिफ्रेन्ट इन्टरनेसनल अर्गनाइजेसन, सोकल्ड ह्युमेनिटेरियन अर्गनाइजेसनहरूले अलिकति केही नराम्रो कामहरू गरिरहेको कि जस्तो लाग्छ मलाई। अर्को रेस्ट्रिक्टेड सर्भिसेस फर नन कोभिड पेसेन्ट, इन्क्लुडिङ इमर्जेन्सी सर्भिसमा पनि त्यो प्रब्लम आइरहेको छ रिफरल मेकानिजममा। त्यसैले मिनिस्टर अफ हेल्थ एन्ड पपुलेसनले त्यो कुरा पनि ल्याएको छ, रिफरल गर्दाखेरि चाहिँ वे अफ कम्युनिकेसन राम्रो हुनु पर्यो भनेर। पेसेन्ट टेकिङ मेडिसिन एन्ड हेल्थ सर्भिसेस थ्रु हेल्थ इन्सुरेन्स स्किम जियो प्याराडाइज। गभर्मेन्ट हेल्थ इन्सुरेन्स गर्छु भनेर 3500 तिरेर मान्छेहरू आए, अहिले सर्भिसै दिएको छैन, मेडिसिन पनि पाइरहेको छैन। त्यो मेडिसिनहरूले गभर्मेन्टले आफ्नो वार्ड प्रतिनिधि मार्फत गाउँ गाउँमा बाँड्न सक्थ्यो होला नि त, रेगुलर मेडिसिनहरू डायबिटिसको, हाइपरटेन्सनको, त्यो त गर्न सकिन्थ्यो। त्यो कुरा गर्न सकेको छैन। ब्ल्याक मार्केटहरू, भेजिटेबल ग्रोसरिजहरू नेपालमा भएको खानेकुराहरू कुहिएर गइरहेको छ किसानको, इन्डियाबाट ट्रक आइरहेको छ, कहाँबाट आउँछ थाहा छैन, ओपन बोर्डर छैन भनेको छ, क्लोज गरिएको छ भनेको छ। सोसल डिस्क्रिमिनेसन अफ पिपल कमिङ फ्रम एब्रोड र अहिले चाहिँ उपचार गरेर गएकाहरूमा एकदमै डेन्जर छ। यो कुरामा हामीले धेरै काम गर्नुपर्ने छ। अब सोसल डिस्क्रिमिनेसन अफ हेल्थ केयर वर्करहरू, फ्रन्टलाइनरहरू, डक्टर नर्स मात्रै होइन, स्वास्थ्यकर्मी, सुरक्षाकर्मी, इभन सञ्चारकर्मीहरू, कम्युनिटीबाट र हाउस ओनरबाट र आफ्नै घरमा पनि अलिकति डिस्क्रिमिनेसन फिल गरिरहेको छ। पिपी डोनेटेड बाई डिफ्रेन्ट अर्गनाइजेसनले पिपी डोनेट गर्यो, तर त्यो पिपी लगाएपछि कोरोना नगयो सर लाए जस्तो आफै कोरोना उब्जिने खालका त्यस्ता खालका पिपीहरू बाँडेको छ ठुल्ठुलो अर्गनाइजेसनले होइन। अब त्यहाँ त्यो कुरा नगरौँ, सक्न आँटेछ र मैले। र अर्को भनेको एनी एप्रोप्रिएट डिस्ट्रिब्युसन अफ पिपी, जुन पिपीको सेट र N95 मास्क चाहिँ मान्छेले पोलिटिकल प्रेसरमा बाँडेको छ कि डक्टरले पाएको छैन, फ्रन्टलाइनरहरूले पाएको छैन, रत्तेउली खेल्दा पिपी लाएर पनि नाचेको छ भनेर आयो भने चाहिँ सोसियल मिडियामा आएको थियो। रेस्टुरेन्टहरूमा पनि पिपीहरू लगाइएको छ। अब त्यो कति एप्रोप्रिएट हो? अथवा जुन एउटा फ्रन्टलाइनरहरूलाई उपचार गर्न, फ्रन्टलाइनरले जसरी चाहिँ कोभिड पेसेन्टलाई उपचार गर्न चाहिने पिपी सेटहरू थियो, त्यो चाहिँ इनएप्रोप्रिएट डिस्ट्रिब्युसन भयो विथ पोलिटिकल पावर हुन सक्छ प्लेस छ। त्यसले गर्दाखेरि अहिले मैले सुरुमा देखाएको थिएँ हाम्रोमा पिपी को चाहिँ स्टक एकदम कम भएर गएको छ। So these are the some challenges, opportunity and challenges, strength, weakness, opportunity and threat, and these are references. We have many more. So I would like to acknowledge our team members, Dr. Parajuli and other supported team member, administrator, and our minister especially. I would like to thank Chief Minister for providing this platform, as well as UK Nepal Doctors Association and Dr. Ramesh and entire team. So thank you very much. And we'll have, if we have any question and queries, we can discuss. So we'll try our best to discuss with you all and to grab some advice for improvement of control and prevention of COVID-19 in our province. Thank you very much.
Thank you, Dr. Surya, for that detailed presentation. Now, I would like to go to Dr. Anup Karki. Hazurle slides upload gariraheko belama there is one question. I'll take one question, then go to Dr. Anup Karki when he uploads the slide.
Okay, sir.
Any questions? Chat ma koi question airaheko chaina yataबाट question. हाम्रो Dr. Anup Karki को पनि similar topic भएको हुनाले once he presents, so we can come back to the question again. So I would like to invite Dr. Anup Karki, who is consultant in dental public health in Wales, and he is currently deployed in dental public health in Wales. So हामीले प्रदेश वनबाट detail यो very analyzed presentation सुन्ने मौका पायौं, त्यस्तै गरी वेल्सबाट हेर्यौं similar field, अनि त्यसपछि हामीले एक आपसमा सिक्ने मौका त पाउने नै छौं र अलिकति डिस्कसन गर्ने मौका पनि पाउने छौं त्यसपछि. हजुर Dr. Anup Karki, welcome and thank you. हजुर.
Thank you. सबैलाई नमस्कार. सुन्नुहुन्छ? सबै सुन्नुहुन्छ?
सुन्नुहुन्छ.
Slides देखिया छ?
हजुर छ.
Thank you for the invite, and especially Dr. Koju. Koju दाइले अब प्रेजेन्टेसन गर्नु त भन्नुभयो. अब के प्रेजेन्टेसन गर्ने भनेर हिजो राति चाहिँ slide I was trying to pull together some slides. I don't have the expertise. I'm not expert in corona management or pandemic management. As Dr. Kamal Aryal said, I work in dental public health, look after the oral health portfolio in public health Wales. Just to give you a brief background about myself first. That building you see there looks like a call center, and it has become a call center during this pandemic. That's one of those buildings is a Public Health Wales building in Cardiff, which is headquarters of Public Health Wales. And on your right, on your slide, you'll see the map of Wales. Just to give you a brief health structure in Wales. Public Health Wales is a national public health agency providing public health advice and support for all whole of Wales, as well as the Wales government. We've got a local government here. While most of the things happen from Westminster government in London, mainly health and education is a devolved matter for Wales to manage. So structurally, we got 7 health boards, and now Dr. Koju works in Howrah University Health Board. As you can see, some quite west and rural health board. And you can see lots of hospitals dotted around Wales. And those hospitals have got microbiology labs, which belong to Public Health Wales. So although the headquarters for Public Health Wales is in Cardiff, we also got local public health teams in each of those health boards. And we also got obviously our microbiology team within those hospitals. And locally, health boards work very closely with councils, Nagarpalika bhanau. So that's the pretty much broadly how health is structured in Wales. So each health board are responsible for providing healthcare services for the local population. And Public Health Wales provides some services like screening, as well as microbiology, but mainly it's an advisory role and coordination kind of role. try to go to the next one. So, as I said, there's a saying in Wales, I'm sure it's in England as well, I'm not trying to teach grandma how to suck eggs. You guys are more experts in corona than me. You've seen so many patients, treated them. So I'm just, as my title says, I'm trying to give you my personal experience over the last 3.5 months, and hopefully there's something in it that you think, oh, okay, that's useful. And also, as I said, I work for Public Health Wales, but I can't speak for Public Health Wales. I can't even speak on behalf of my wife, let alone Public Health Wales. So these are purely my personal views and personal reflections, just to clear that out of the way. So that picture on the right also kind of represents me, how I work in the office. In a sense, I drink lots of coffee, doing my work from the desk, but it's more of open plan office. On 5th floor of that building I just showed you, and 4th floor of that building is the health protection floor, where most of the action happens now, if you like. But, and as you can see on the left-hand side, that's a brief timeline with my personal experience, in a sense. So we know about when did corona started, and the first case in corona in UK was on 31st of January, but it didn't arrive. The first case in Wales didn't start until well, 28th of February, and everything was almost like a business as usual. For me, I was working, March is a busy month for us. And so we are working on in terms of what we did over the last 11, 12 months. And you have to prepare annual reports, project reports, and you also look at the budgets, where did you overspend, underspend, that sort of thing. So that's what I was trying to do. And although the corona had started in the UK, in the sense on 31st of January, almost most of us were working almost as a business as usual. Maybe we shouldn't have, I don't know. So that's for a question to think about. So on one of those days, around 1st or 2nd of March, I was on my 5th floor working on my own portfolio. And one of my consultant colleague came from 4th floor. As I said, 4th floor is where the health protection floor is. And say, we need your help. We need someone downstairs. We need someone to come and help us with the contact tracing. And literally, I was working on my computer, wrong place at the wrong time, I suppose. So my consultant colleague just dragged me and the other, one of my other colleagues to the 4th floor. And that's how I started my, if you like, work experience, I call it, on 4th floor health protection. So contact tracing cell, there was a contact tracing cell within the 4th floor. So that contact tracing cell's job was, as it says on the tin, contact tracing, and then we stopped doing contact tracing in the UK on 12th of March. I'll come to that in a minute. And then my experience of working within the coronavirus was more in trying to support what we call enclosed settings. There are care homes, hostels, people put in hotels were homeless before, refugee hostels, that sort of thing. So all the enclosed settings, we set up a cell called enclosed setting cell, and then we try to help them to prevent and control the outbreak if there was an outbreak. So, as I said before, we stopped contact tracing on 12th of March. On that day, 25 cases in Wales, which isn't that many. So, but we stopped contact tracing. And one of those cases, even within those short period of time, most of those cases were from overseas, who had come into Wales from mainly northern Italy, and few other places. We used to call them category A, category B countries, and category A being more high-risk countries. And even within those 25 cases, we did have asymptomatic positives. So they were not, some of them didn't have any symptoms. You may have heard of some cruise, people in cruise who, Diamond Princess, who have lots of cases were not positive, were positive, but were not symptomatic. And even within those 25 cases, we also had cases which were not from overseas. So basically, someone hadn't gone to overseas in one of those high-risk countries, but one of those cases was local transmission, basically. So within 25 cases, we had almost proof that local transmission was already happening. But obviously, I come back to the point that we stopped community contact tracing on 12th of March. And I call those 25 cases almost like a tip of the iceberg, because those are the cases which, again, mainly focused on who came from overseas. We had those cases given to us either by the port authority, they are called, or Public Health England, and then we contact traced them. But then we already had evidence of local transmission who had no history of travel. So obviously there are lots of cases out there in the community which we hadn't stopped even by then, by that day. And as the contact tracing stopped, the whole country, including the whole UK, and that's the same day England stopped contact tracing as well. At that point in time, there was a unified UK-wide approach in what we did. Even the guidelines we used for contact tracing and everything was UK-wide. So it wasn't decided locally in Wales that what we did or what we didn't. So once PHE stopped contact tracing on that day, we stopped as well. And what we were told was we'll have a lockdown soon, so that's why the contact tracing wouldn't be required. And I've got a newspaper cut from on 14th of March. Within 2 days, as you can see, from 25, we already had 60 cases. So it was spreading fast. But then lockdown only came on 23rd of March. So there was a 12 days gap. As I just pointed out, 25 cases jumped to 60. And as I call that, tip of the iceberg. And then we had 12 days gap between that and the lockdown on 23rd of March. And you can understand the decision-making process just takes time. And that's where the risk is as well. So you don't have luxury of time to make decisions in pandemic. And lockdown, as you know, it has happened across the world. And I think personally that, and we know it's one of the costliest public health interventions ever happened, I suppose. In every sense of the word when I say cost, not just money-wise. So just going to the couple of things in terms of consequences of public health event and control measures. There are social consequences, there are scientific consequences, economic consequences. There may be positive or negative consequences for environment, ethical, policy, and political. So it's a nice, easy stick. It's called STP stick, and you can use other framework you can use. You can say, if you go through those, you can almost easily go through what are the consequences of public health events and the control measures. But you can also use these factors, if you like. People will use, mainly the decision makers, and maybe that could be the Prime Minister or a CEO of an organization or a Chief Minister as Province 1 Chief Minister. They will probably use combination of these factors in the decision-making process. So when we hear in press briefing that our decision is based purely on science, I personally don't believe that. It's never believed purely based on just science. There are other constitutional factors like that. which have got bearing on decision-making process of any government, or even at a local level or lower level. So I suppose when they say we're using that science as a key factor in driving the decision making, they probably hadn't used science as much as they, in the normal context when they didn't have a pandemic. So usually at political level, decisions are evidence informed. They are never evidence based as we understand in medicine or healthcare. So moving on from 12th of March, when we stopped doing contact tracing, then we had to, and then lockdown didn't happen for 12 days. We knew there was going to be outbreaks because we knew that community transmission was happening. So for those 12 days, we were purely relying on health messages out there through different medias. So we created this enclosed setting cells. Again, most of us who were working on contact tracing got transferred to this setting, and the whole fourth floor became almost like a call center. So, and then we also set up, I call it call center, they look like call centers. So call center in West Wales and call center in North Wales as well. And they will take a number of inquiries and various questions from public, any organization, any healthcare workers. And then any that's related to any settings, enclosed settings that came to our cell, and we dealt with those inquiries. An idea of that setting was purely to control the prevent outbreaks, and our focus was for various reasons was care homes. There are around more than 1,000 care homes in Wales. And by the time we finished, we haven't finished as yet, but I finished my deployment, if you like, into that closed settings last week. Friday was my last duty on that setting. And we've moved into, because the contact tracing has started again, because of as the UK is trying to ease down some of the lockdown measures and slowly opening up. The contact tracing has already started, and lots of us who were working on that fourth floor on Cardiff have been redeployed into 7 regional teams. So, which follows the footprint of 7 health boards in Wales on that map there. And as I mentioned before, we already have 7 health boards have got local public health teams. They have got directors of public health, and they are also got 22 councils in Wales, and councils have what you call environmental health officers and others who could help with the control of outbreaks locally as well. And 94 teams set up on the footprint of super output area called, they are statistical areas. 94 contact tracing teams, they work with the regional teams, and the regional team works with the central team in Cardiff. So it's a tiered approach of managing the outbreaks that are bound to happen as you ease the lockdown. So by the time I finished working last week on enclosed setting cells, we supported about 884 settings. 615 of those were care homes, which had outbreaks. And luckily, as I said, there are about 1,100 care homes, and so many are still green. So many are trying to get over the outbreak. And some of those care homes started those outbreaks because of the discharge from hospitals, I think. And many were from communities, but also some of them were from hospitals. So people getting admitted to care homes from their community, as there was a community spread, quite wide community spread of corona, but also from hospital patients being discharged. And that, as we worked through these enclosed settings, there were lots of noise in the system, media interest, and all of those care homes, those of us who are in the UK, have heard about death and how government failed to control outbreak in care homes. It was on the news, is still on the news. And some of the criteria we used on the care home setting were different from what we used in contact tracing. It was all about risk assessment. I'll come to my later slides what I mean by that. So we had a low threshold of risk-taking attitude within the care home settings. For example, one of them being isolation. We isolated anyone who was positive or even negative or any symptoms for 14 days, as opposed to we advise to isolate for 7 days minimum or more if you still got symptoms for general public. So, and also symptoms wise in the UK for contact tracing now, there are just 3 symptoms used: temperature, or continuous cough, or loss of sense of smell or taste. But in care home settings, because of the kind of population you have there, the symptoms we used was quite wide. So anyone had any kind of symptoms, any suspicion from care home staff, from delirium to fall, because we found lots of cases where they didn't have typical symptoms, but then when you tested them, they came out positive. So older people with lots of multiple medical conditions and immunocompromised in that sense, during our experience in working in that setting, that many of them do not show typical symptoms. So you have got to have high degree of suspicion on those population. So unfortunately, pandemic has killed lots of people in the UK as we know it. And one of the, I think from 31st of March was about care home. So initially we had problem, as Dr. Parajuli described before, and really impressive kind of work happening in Province 1. UK had, even as a developed country, UK had massive problem in PPE supply, and because of the global demand, I suppose, that's what we were told, and UK hardly manufactures anything itself. And care home initially weren't prioritized to get those PPE, and in Wales it is council, Nagar Palika Bano, and it's their responsibility to supply PPE to care homes. And even when we had lots of outbreaks within these care homes, the supply wasn't sufficient. And then testing became a big noise in the media, as we all know, those of us who work in the UK. And testing, initially there wasn't enough testing in care homes. Then it became more of a political testing rather than the testing for public health benefit or outbreak control reasons. So it swung from limited testing, which it wasn't adequate, to the extent that it was overdone. Just to give you an example of how it swung from one to the other was, even until last week, so many care homes in some of those health boards were tested whole home every week. And as a part of that, the unintended consequences, I suppose, was so many of those care home residents we had already tested and were positive, had done their 14 days of isolation, and then basically they came out of isolation within those care home settings, from their own room within those care homes. But then we know virus can last in people's body for a long time. So they got retested, they were still positive. So after 14 days, if they are still positive, what do you do? Again, not taking any risk, the advice from our infectious disease doctors, they are called consultant in communicable disease control. They said, we don't know if it's a new infection or if it's an old infection. I'm not taking risks. Let's re-isolate them again. So that was the unintended consequences of testing. Although our advice from public health advice was not to retest those people who tested positive and have already recovered. So unless they develop new symptoms, don't test previously positively tested residents. But it got tested as a part of that policy. And similarly, one of the other challenges Wales is facing at the moment is government announced. So government announced that none of the hospital discharge, basically hospitals should test their patients and they should be negative before they go into care homes. Similarly, any care home transfer also has to have negative test before it happens. And also anyone who wants to go from their own home to care home also needs to have a negative test. And that again has multiple unintended consequences. And trying to apply that policy blanketly has got multiple challenges. And so how we dealt with that policy in terms of implementation from that setting was basically case-by-case discussion, which took a lot of time and hassle and lots of queries. So when I left last Friday, we had probably about 10,000 emails we answered. We couldn't even count the number of calls we had to deal with. We couldn't deal with the direct, we had a dedicated line, 0800 number to ring us directly on that cell. We couldn't deal with that. So we diverted all calls to those 3 call centers I described you before. They'll take the basic details and then pass it on. And we had basic software called Tarian that's usually designed for to deal with health protection incidents over the years, but that was designed to deal with mini outbreaks. So we had to use what we had. So just bringing a point that IT system is key in managing this outbreak as well, because it is impossible to do on a paper-based system. And then that IT system wasn't designed, isn't really fit for purpose to manage pandemic. It was designed to manage outbreak in a couple of care homes. As I mentioned, by last Friday when I left, that we had more than 600 odd care homes and 200 plus other settings in our system. So we created them as incidents and outbreaks, and then monitor them on a weekly basis to make sure that they were doing everything they're supposed to do. And because of all the noises in the system about PPE, testing, and various other contextual factors, as well as some of the government policies, so much of our focus got diverted away from what we're supposed to do in terms of how we got established, because you have to deal with inquiries. And then sometimes I'm sure we missed the focus of our attention had to be infection prevention and control to control that outbreak or prevent outbreak in any new care homes. That got diverted because there was so much noise we had to deal with because of sometimes policy, sometimes rumors. As Dr. Parajuli said, there's always infodemics, misinformation, disinformation out there, and then people bring you to clarify. So if I move on to the one of the slides that this gives you on my right-hand side is the Wales figure of death in all settings, and the pink one on the top gives you how many people died in care homes, and the bottom one gives you how does current year death, excess death, if you want to call, compares with 5-year average over the years. So as you can see, because of the pandemic, there has been extra deaths, and part of those happened in care home settings, mainly in hospitals. But good news is it's coming down, and obviously there's always a lag between someone catching a virus, getting infected, and then developing symptoms, and then eventually hospitalization and death. So all the measures government put in, and the key one being a lockdown, we basically reaping the benefit now, but then we again easing the lockdown slowly and then it'll be key going forward to monitor what happens. And this is just 18th of June figure, just 1 day figure. It's important to have the overall cumulative death and cumulative positive test and all that sort of thing as a surveillance, but it's also important to monitor what happens on a daily basis. And as you can see, some of those urban areas, Swansea, Brisbane, Newport, Cardiff, had lots of cases at the beginning. They're urban areas, but now they have got less number of positive cases there. And you can see some of the spikes there. And I can tell you the one in Anglesey, one in Wrexham, those two spikes because of those, there are 2 outbreaks. It's on the news out there. They have 2 food factories who had outbreak within the food factories. So this kind of information is useful to not just for the planning, but also to mobilize the workforce. So for example, I described you about redeployment into 7 health boards. So one of the health board at the moment is quiet in terms of the workload. So they are helping out the health board which has got these outbreaks. So they've been again redeployed, but then again helping out to other areas. So that flexibility of workforce deployment is key in managing these outbreaks. So again, coming back to the basic, I suppose, with my experience of last 3.5 months, although I've kind of pointed out, listed them as separate entities, there is always interdependencies of these things. And when I reflect on things, I reflect slightly structurally in that sense. So we all probably, those of us who work in UK, and Dr. Parajuli just mentioned as well, and there's huge work legislative-wise to make legislations, specifically for corona. One of them being it became a notifiable disease. There's Corona Act and all that sort of thing. But it's the key, which again, Dr. Parajuli also mentioned, that without coordinated planning, be that at UK level or Wales level, or even at a local or regional level, that coordinated planning is so key to make sure the implementation happens in the right way. Us in the ground, I call it, on the suffer a lot if that coordinated planning doesn't happen on the top. Risk communication plan is key, and that's again at every level, from government, UK government to West government to health board level to our organization level, and even I would say that call center level. Communication is key. Lots of noise in the system and lots of inefficiencies in terms of dealing with the noise happens because of the, if we don't have a good communication plan, and risk communication and engagement with the public is also key. And we've all heard before, as Dr. Parajuli also mentioned, your daily briefing from government to local and using different media. And one of the things which is also key is the program management approach. All the logistic and the support, I call them unsung heroes, who are not on the front line, but they make the work of front line easier. Without them, it's impossible. So be it that make someone fixing the IT. For example, one of the contact tracing days, we had cases came into contact, but we didn't have a IT system went down. That system which was designed to look after few outbreaks, we had already so many incidents, it crashed. So we needed IT to come quickly and fix that. And testing capacity. Initially, we didn't have enough testing capacity. So microbiology labs in those hospitals, as well as our microbiology lead within Public Health Wales, work day and night. you could see him pacing up and down on the 4th floor, always on the phone, trying to increase the testing capacity. And surveillance system, again, I showed you some of the graphs. It's getting better, but the way it happened in terms of we stopped contact tracing, testing capacity wasn't there as much as it should have happened, and testing was focused mainly on a hospital setting. The surveillance system took time to build up. It's slowly building up as the testing capacity has gone up, but it's taking time. And I come to my previous point of focus on infection control and prevention and control. Most of the control measures, although we focus on testing and big items like healthcare, some of the less costly items and the constant focus are equally effective. The effect usually adds up, doesn't it? So it's not just one item of one intervention that helps in a pandemic. It could be, it's the social distancing, it's the use of masks, it's the use of PPE in healthcare settings and other settings. It's how you do laundry in care homes, how you interact socially, all that sort of things adds up. And on my reflection in care homes, sometimes, as I call it, noise, as you're dealing with so much, sometimes we probably forgot that our key role was to support those care homes so that they got all those measures they're supposed to put in care homes to control the outbreaks to be spot on. So we're dealing with all the inquiries. I don't have to talk about healthcare facilities and laboratories. It's not too dissimilar to all the tier level Dr. Parajuli described. We have similar tier system in Wales, main hospitals being tier 3 tertiary centers, and then there's what you call the established, even temporary step down, step up facilities. So they are basically intermediate settings where people who don't need to go to hospital can go there, or people who can't be discharged directly to care home or can be directly discharged in their own home, but they still need some sort of rehabilitation, go to that intermediate facilities. And then you've got other primary care as we do in the UK. And again, other thing which Dr. Parajuli touched on which is key and which again got basically it stopped, is key essential services. Even on pandemic, you do need some key essential services, ongoing services in terms of public health. One of them, example being childhood immunization. I mentioned screening services. We stopped screening services, and quite a few of those colleagues, radiographers to consultants who work in those screening services, got diverted to work with me and others in inflow setting cells, as well as other areas within health protection. So we couldn't continue those services. Now there's a plan Wales-wide to restore some of these essential services. And WHO obviously has got a list of essential services which it says needs to continue even during the pandemic. Otherwise, it will have severe short-term, long-term impact, and more people will die from other things. And at the organization level, and I'm sure it's also for the country level, business continuity plans and workforce plans are so key. And personally speaking, from how my own organization dealt with in terms of playing its role in controlling the pandemic, we always had business continuity plan, we always had a workforce plan. Having a plan is one thing, but having some of the, on a regular drill, if you like, is also important. And drill to the extent that you just don't drill on emergency planning and preparedness of at the plan level and more high level. For me, it needed to be also drilled at, have a drill at a more operationalized level so that we could see the effect of that. So, as I said, it's in a way, the whole thing for me is a risk management, risk assessment and management, be it at that country level. And it depends on the risk attitude and all those factors politicians take into account when they make decisions, when they see the risk assessment, and then they put a control measures at a state level, or we put a control measures at regional level. But there is no such thing as zero risk. It's all about taking the certain level of risk the society, community, and the country is comfortable taking. And as I mentioned before, risk communication stays at the heart of that. And getting those that risk communication is key for the success of pandemic plan as a whole. I'll just put it out there. As you can see, the press people have been asked to socially distance, but people leading and managing are not socially distancing themselves. And that's a huge challenge for anyone trying to communicate risk to the public, saying social distancing is important. And I personally like one of the things we use regularly in public health and other areas in planning you think it's got severe impact, and it's the likelihood of incident happening is high, then as you can see, you can your decision when you think it's red versus when you think it's amber or yellow or green is different. But there is always a subjective element and all the other contextual factors people take in when they make these decisions. And it is difficult. It is difficult to communicate risk. As you can see on the top right-hand corner, that was one of the lockdown day in America, and it was a nice day. People, and if your leaders are not leading by examples, then people will not follow those communication, your advice, whatever you want to call it. And also it's a very difficult thing because science is evolving for coronavirus. So there are uncertainties about the science, but how do you say that depending on your audience? If your audience is healthcare professionals, then your language and the thing you say to them would be different versus what you're saying to the public out there at large. So in public health, there's a good saying that if your 10-year-old cannot understand what you're saying, that's not a good public health message. So I've just put a cut from which Dr. Parajuli also mentioned Ministry of Population Health in Nepal. It's got really, really good information site there. It updates every day. And I just quickly had a look. It's got frequently asked questions, and none of those questions. I'm not saying I'm not trying to pick out and saying it's wrong. All I'm saying is it's difficult to communicate when the science is uncertain, and none of if you can read those question and answer in your own time. None of those answers are wrong. But if those questions and answers are targeted for your public, I don't know how would you take that. So all I'm saying is I wouldn't have written those answers in that way if that was targeted for public. As I said just now, 10-year-olds should be able to understand what exactly to do if it's targeted to the public. And although, and it's a really, really challenging thing to give to the public, the uncertainties around coronavirus. So risk communication, public health communication operates, you need transparency for public trust, you need reliability, and you need trust. And that's a given. That's not just for public health communication, that's for any communication. For public and people to trust, they need to feel and at least perceive that it's transparent, it's reliable information, and they can trust after it. There is a cut from on the left-hand side of my screen. Chief Medical Officer in Scotland had to resign because he broke her own advice. And there's another one saying Boris Johnson, UK Prime Minister, was hospitalized because of the COVID. If you want to tell public that how dangerous this virus is, you couldn't communicate that any better. That just one incident gave out such a message of risk from this virus. But then again, as Dr. Parajuli also mentioned, there are so many misinformation and which go viral very quickly. And that's the challenge of communicating to the public in the midst of using various different medias. So those, for example, UK does, as Nepal does, daily briefings, but a significant chunk of young population wouldn't watch that. So how do you use other modes of communication which reaches the other sections of the population which do not use that medium? It's always a challenge. So it's a huge task and a huge ask. So out of all this negative and awful environment and awful pandemic we have, then we've got to focus on positives, including my own experience of working in health protection setting, which I had a training on but never worked on. I worked with so many colleagues, met so many people, made so many friends, and made so many networks. That wouldn't have happened without this pandemic. Same with, I've just put some pictures out there, how it looked before pandemic and how it looked, one from Delhi, one from Venice. Beautiful, looks clean. Just on that note, I'll just end that there. Thank you.
Thank you. Thank you very much for that presentation, Dr. Karki. I would like to question one thing. You touched onto this contact tracing, and many of us have heard about it. So could you tell us a little bit about what is exactly done when we do the contact tracing? So one of the things we have heard is if somebody is found to have coronavirus, COVID-19, then you take a history who has been in contact with that patient. And then if it is more than 10 minutes or 15 minutes, whatever, then do you isolate that contact, or what is exactly done? So that is first question. The second one relating to that, we hear about a lot of apps. Apple, then the Isle of Wight app. So maybe those two things, if you could clarify us a little bit, please.
So if I go back on what I did in the early contact tracing days, early March, the guidance has slightly changed from there. As I said, the science is evolving. So the contact tracing guidance they currently being used now in Wales, and I'm sure that's same in England, is slightly different from what I used when I was doing the contact tracing myself. So contact tracing in principle is a well-established function in public health. In health protection, they do it on a regular basis. So for coronavirus, whenever the case, mainly early days, when they came in from different countries, they were isolated. We had a contact number from Port Authority, and then we contacted them. Some of them already had a test done, so we knew they're positive. But if they hadn't had the test done, we organized tests. And when they became positive, and then the contact tracing started. So what happened in the system is, as soon as the microbiology lab in Wales finds a positive, that gets to our IT system, if you like, it automatically gets notified in our IT system. So every morning, you'll have a list of positive cases popping up on your IT system. So that may be 5, that may be 20, that may be 10, depending on. So initially, we just had up to 5, 10. It came in batches like that. Once you got those positive cases, then the first thing, you quickly contacted those positive cases. And then I'll describe you when you can't contact positive cases. So and then you take a history, as you just mentioned, Dr. Adel. So you take a history on contact tracing, when we did it back in March, we started from the contact from the day of symptoms. And then if anyone, as you mentioned, came in within 2 meters for 15 minutes or more, then they became a contact. Or it could be less than 15 minutes, but they were in very close contact, skin to skin contact, or somebody coughed at you, or any suspicion that the duration of 15 minutes is less than 15 minutes, but there could be a significant contact, then they also class as a contact. So we advise those contacts as soon as we interviewed and established, and that's for the duration of the symptoms. So from the onset of symptom, for the whole duration of symptom, whoever came in contact with, and then we got their details from the person who was positive, and then contacted them and asked them to isolate. And those contacts, if they were positive, they were tested. And if they were not symptomatic, they were asked to isolate. And then whenever they developed symptoms, they were tested. And then if the asymptomatic contact becomes symptomatic during their 14 days of isolation, their isolation period, the clock restarts, if you like. So the isolation becomes longer when you are either negative or asymptomatic. So if you, for example, if I've advised a contact to isolate for 14 days, and on the day 1 to day 13, they are not symptomatic, but on day 13, they develop symptoms, the 14-day clock restarts. So they could be isolating for longer. That's because usually on average, it takes 2 to 5 days for the symptoms to appear. Not all develop symptoms, but up to 2 to 5 days, as I understand it, but it could be up to 14 days. So the range, as I said, the science is so uncertain at the moment. So someone can develop symptoms from day 1 up to day 14, average being 4 to 5 days. What's slightly different now in terms of contact tracing is, as I said before, we used to contact trace any contact from the day of symptom. Now we know people can be infected pre-symptomatic. So the current contact tracing uses 2 days before the symptomatic. So any contacts who have come in contact with the positive case up to 2 days before the onset of symptoms, and then during the entire duration of the symptom, they can become a contact. So that's the slightly tricky part at the moment. And there are two proposals, if you like, in Wales for this next phase of contact tracing. One was to just contact trace once you find out someone positive, or do you start contact tracing as soon as someone becomes symptomatic? So if you start contact tracing as soon as someone becomes symptomatic, obviously that has got resource and you need an army of people to do contact tracing. And then that has got implication in terms of the testing, but also has got implication of you may wipe out, let's say, a care home or a hospital by contact tracing. The whole workforce can be wiped out by contact tracing just based on symptoms. The Wales, I'm not sure in England, but the Wales decided to only contact, and again, I come back to the point of taking a risk, how much level of risk the country is prepared to take. So the contact tracing that happens now in Wales is based on once the positive cases are notified, then the contact tracing starts. So for that, we've got 94 teams out there doing that. Does that answer your question?
Thank you. Thank you very much. So antibody testing, quickly, if we could touch into that. Dr. Khan has raised the question about antibody testing. What is the importance of antibody testing?
For me, as far as I understand, again, I'm not expert at it, but at the moment, there is a limited value of antibody testing. I know it has started in England. A couple of my friends have been offered for antibody testing. Wales is also going to start antibody testing. Again, it's not out there in the plan, but I've heard we're going to start with hospital healthcare staff and then may offer to teachers and other key workers, as we call them. It's definitely useful in terms of research and trying to understand what proportion of population has already been infected and recovered. The one I understand being used in UK is testing for IgG. So it will give us the proportion because, as I said before, the testing sometimes it's tip of the iceberg. It doesn't pick up all those people who have probably had infection and the testing wasn't done, but they recovered. So it gives a better picture combined with the PCR testing, what proportion of people got infected in the past. Because as I mentioned before, we stopped contact tracing and lockdown meant we don't know how much coronavirus is spread in the population and what proportion actually recovered. And the reason I mentioned its limited value at the moment is we don't know, or we don't have the evidence if once you got antibodies, how long is that protective, or is it even protective? That if you got antibodies, there's no evidence as such at the moment that you're not going to get reinfected. Is that? And the B, we don't know if that antibody is, even if it's say, if we're going to get, say, for example, research tomorrow saying, yep, antibody is protective, which is great news. And then how long does that last? So just again, with my limited experience, we do annual flu vaccine. And that every year, the vaccine is changed. Every year, this effectiveness is different. So answer is, I don't know at the moment. I think there is a limited value. But if we got better evidence that antibody is protective, we got better evidence that it lasts for so long, that's great. That's a big, big win. But at the moment, I would say, we have to start somewhere, don't we? So getting that data now, and then if you start cross-linking those, you can link database together. So if you've got a antibody data of people, and you've got a PCR testing happening on the ground as you speak, you can link those and see what proportion of those who already got antibodies have got new PCR tests and are turning positive.
Thank you. Thank you very much for that. I would like to ask Dr. Shankar, you want to say something?
Yeah. Thank you very much. Dr. Anup, धेरै राम्रो प्रेजेन्टेसन थियो तपाईको। म नेपालीमै सुरु गरेँ। केही जिज्ञासाहरू मेरो कस्तो छ भने एज अ क्लिनिशियन पनि जिज्ञासा हो र एज अ अब अहिले यो प्रोभिन्सको मुख्यमन्त्रीको एडभाइजरको हिसाबले पनि पब्लिक हेल्थ पार्टको पनि मैले केही कुराहरू भन्नुपर्ने हुन्छ। त्यो भएर मैले यो अपर्च्युनिटी लिएँ तपाईसँग। यसो सरस्वती डाटा हेर्दाखेरि 3-4 दिन पहिलेको युरो न्युज या सीएनएनमा मैले सुनेको थिएँ जब युके को डेथ रेट 40,000 को करिब हुँदाखेरि एउटा कन्ट्रोभर्सी न्युज आएको थियो, वेदर इट्स 50,000 और 60,000 दुईटा भिन्दै भिन्दै एजेन्सीहरूले पनि भनेका छन् भनेर। तो मलाई चाहिँ किन इन्ट्रेस्ट भयो भने एज अ क्लिनिशियन हस्पिटलाइज भएका बिरामीहरू तपाईको आइसियु सिसियुमा गएर भेन्टिलेटरमा रहेर निस्किन नसक्ने डेथ रेट हाई हो या कोमर्बिडिटी भएका पेसेन्टहरू चाहिँ मोर भन ट्रेसिङ या ट्रेसिङहरू चाहिँ या आइसोलेसनका कुराहरू कहीँ पुअर भएर हो, पब्लिक हेल्थको पार्टमा हो भने त्यो कुरा कतै केयर होमका कुरा भए या होम आइसोलेसनमा प्रोपर भएन या अझै पब्लिक हेल्थ एक्टिभ भएन भन्ने कुरा पार्टमा आउँछ। त्यसले गर्दा हामीले के लेसन लर्न गरौँ त? के लाग्छ तपाईलाई एज अ पब्लिक हेल्थ को पार्टले त्यो पार्टमा एउटा त्यसले हामीलाई के हुन्छ भनेदेखि हामीले आफ्ना प्रिपेयर्डनेसलाई के गर्ने, किन हाम्रो कन्स्टेन्ट त थाहा छ यहाँलाई, हस्पिटल पुअर त्यस्तो म्यानेज छैन, प्रोपर आइसियु सिसियु भेन्टिलेटर छैनन्, त्यो पार्टमा पनि हामी अलर्ट हुनु पर्यो। अर्को पार्ट चाहिँ तपाईबाट लेसन लर्निङ के हो किन यति झन्डै 14% चाहिँ अहिलेको डाटा हेर्दा पनि 42,000 भनेको चाहिँ 3 लाखमा झन्डै 14% चाहिँ डेथ रेट भनेको 5th पोजिसनमा इन्फेक्सन रेट भएको कन्ट्रीमा यो भेरी हाई हो। हामीले देशलाई हेर्दाखेरि हामीसँग कम्पेयर गर्दा के भन्न चाहन्छु प्लिज?
ओके, फर्स्ट पोइन्ट mortality comparing between countries is difficult and troublesome. So पछि आउला अब यो युजुअली पब्लिक हेल्थमा मोर्टालिटीहरु हेर्दा चाहिँ एज स्ट्यान्डर्डाइज रेट भनेर युज गर्छ अनि त्यसपछि तल कम्पेरेबल हुन्छ। त्यसैले इन बिट्विन कन्ट्रीज डेथ रेट इभन पर 100,000 क्रुड रेट गरेर गर्दा अथवा number just mention गर्दा it's quite crude and it gives you some information, but it doesn't tell you the whole story. Point that. अर्को point चाहिँ exactly very valid point. Nepal is in a position, नेपालको position मैले जुन state मा छ, UK has been through that position. And I mentioned, पहिला मैले के mention गरेँ भने त हामीले contact tracing stop गर्यौं, and then lockdown didn't start for 12 days. So there was that gap which led the virus spread, and purely we relied on public health messaging on those 12 days. We had lots of horse racing to football matches to lots of other functions happened during that time. Shops were open, and it was almost like normal other than public health messaging. That, for me personally, that the control measures something needed to be there in those times. You either stop contact tracing and then have a lockdown immediately, or if you not going to have that contact measure, we should have continued, expanded our contact tracing team like we've done now, and then massively increase the testing capacity. That's easier said than done, as I said before, because testing capacity doesn't just, you can't just pluck out of the air. So multiple factors are taken into consideration when they make decision, I'm sure. But I think that, and in terms of stopping that mortality, most of the measures you put it out there, community level ma, population level ma, population measures I think they are less costly. Once once people enter the healthcare system, is too late. That tells you that your community measures hasn't worked as well as it should have. If a mass number of people enter hospital setting, that your community measures isn't working. And I also mentioned not one single measure is effective. It's the cumulative effect, cumulative additive effect, if you like. So everything has to work, and then combined effect is big enough so that most of the people recover within the community, not requiring healthcare. And one of the data I quickly, again, Ministry of Health has got a very good website, and I'm pleased to hear that Province 1 also has got now really good information system there, and then information is key. And looking at that data, Nepal has got good thing going on at this moment. Is most of the positive cases are under 50 years. If you compare that to UK, most of the people who died were over 50, over 60 even. And the highest death rate was on over 70s. And most of those who died, most of those had some sort of health conditions. They had, and one in 5 deaths had diabetes. And recently there was also another research mentioned in the media. I haven't read it, but so many of them were South Asians, even when they controlled for many factors. Is that because there's so much undiagnosed diabetes in South Asian population? Is there because South Asian population have so many workers who do more risky jobs? Or do we have a risk attitude different to other population? I don't know. So, but as you mentioned, different kind of multimorbidity, and in UK and in Wales, all those, because we got a really good primary care system, and GP being the bedrock of that, there's a really good data system, and then system can identify who's got what disease, and many of those people got individual letter during the lockdown saying you should be really locking down yourself in your room and don't come out of the house, because if you get it, you're going to die, kind of letter. And then GPs were also given flexibility that if they identify anything more than that, they can also give those letters to the patient they have in the system. So by that, you're basically informing those people who are more likely to die to be more careful. But as the lockdown is more eased, there is a risk, isn't that? And as I mentioned before, as the lockdown is eased, although the death rate has come down and the incidence and the positivity rate has come down, there's a risk that it could go up again, because what we're reaping the benefit now of having low number of cases and low death is because of the measures we've put in before. So that's why it's in a way it's experimental at the moment, and state-wise approach of taking cautionary approach, at the same time establishing those contact tracing team locally to have some sort of control. Contact tracing doesn't work on its own, as I said before. It's the population behavior also, and coming back to my point of risk communication, and how do you change, how do you have trust in the authority and those people working in this, so that what you advise public and public follow it, like social distancing. And social distancing, 2 meters. And now people are saying 1 meter is enough because of all the other drivers of that. So 2 meter may be more protective, but 1 meter is still protective, but it may be less protective. What's the marginal gain from 2 meter versus 1 meter? So, sorry, it's a long-winded answer, but I think you have to have multiple measures. I would focus more on a community and population level measures. Yes, hospitals and things needs to be there, but I think that it's already too late if a mass number of people needs to go to hospital. And
thank you very much. हाम्रो 2 घण्टा almost गइसकेको छ. हामीसित अझ 2 घण्टा सकिसकेको छ. हामीसित डाक्टर नवराज सुवेदी हुनुहुन्छ. हामीहरुसित के अरु क्वेशन छन् भने पछि आउँला. डाक्टर नवराज सुवेदी, he is our consultant radiologist. He will be talking about the radiology diagnosis. Dr. Karki, if you come out of the screen, that stops there. And Dr. Navaraj, it is my pleasure to welcome Dr. Navaraj Subedi, consultant radiologist. He's from Lancashire Teaching Hospitals NHS Trust. So chest X-ray, CT, as many of us are clinicians here, so I'm looking very much forward to it. What is it that we can see on those CT scans and the chest X-rays? On which basis we may make the diagnosis of COVID-19. Thank you, Navaraj.
Thank you so much. So, सुनिरहेछ हैन?
सुनिरहेछ, राम्रो सुनिरहेछ.
Share screen गर्नु पर्यो आज.
Screen देखिएको छैन.
Screen देखिएन.
एकैछिन.
तपाईले स्क्रिन अपलोड गरिराखेको बेला हामीको अरु क्वेशनहरु छन् भने उहाँको सकिएपछि फेरि आउला हजुरहरु. तपाईलाई स्वागत छ फेरि. I'm sorry, अलिकति ढिलो भयो, तर अर्को आधा घण्टा जतिमा हामी सकिन्छौँ हजुर.
देखियो स्क्रिन?
देखियो हजुर. Thank you.
Sorry. Thank you so much. Those who don't know me, I'm Dr. Navaraj Subedi. I'm a consultant radiologist in Lancashire Teaching Hospital, and also as a senior lecturer in the University of Manchester. I wouldn't take long, I promise you. I'll try to be as soon as possible because my talk is really short. People often ask me what has changed in radiology since since the start of this pandemic, and I always tell them that there are 3 things that have been changed for me, at least in my clinical practice. First of all, that's how I used to go to the hospital. Nowadays, I land up like that. And secondly, what happens is that I do have an opportunity to work at the comfort of my own home, which was a rare phenomenon before the COVID. And thirdly, I did not have any particular interests or expertise on chest radiology. And those words like crazy paving, bronchoalveolar thickening, and interlobular thickening used to sound me like a weird words, but nowadays I'm using them quite often. So those are the 3 things that have been changed since the pandemic. So these are the objectives of my talk. So I'm going to show you a variety of cases. I'm not going to talk about the fact that coronavirus is an RNA virus, these many people are affected in the world and that many in Nepal, because you must have been sick and tired by now that you must have heard it hundreds of times, if not thousands, really. So I'll try to show you the different cases which presented to us in my clinical practice as a consultant radiologist. And I'll quickly go through some of the evidences that have been found in the literature and finish off by showing you or making you aware of some of the BSTI guidelines that has come into force since the advent of this COVID disease. So let's go through the cases now. And the first three are the normal, like, straightforward cases. This is a 53-year-old female who came into accident and emergency with cough and breathlessness, and you've done this chest X-ray, and there's no rocket science here. You can see that there's a bilateral peripheral low predominant ground glass opacities, and these can be described as a classic appearance to the pulmonary COVID. The second patient again came into an accident and emergency with cough and fever. Then we see that these kind of chest X-rays, it's difficult to say because it's fluffy all over the chest. These might be just chronic changes due to smoking history or COPD or anything of that sort. When you see the changes in the lungs, but you cannot say for sure that it's due to coronavirus, then we term it as a indeterminate for COVID. Whereas in some cases, like this is a 61-year-old man who had a known history of head and neck cancer. That's why he's got the VP shunt put in on this one, and then he is tested positive for corona, and chest X-ray can just show the subtle abnormalities. The only thing that we could see was the obliteration of the left hemidiaphragm, and there is an increased shadow behind the heart. And the COVID, the pulmonary appearance of the COVID can be very, very subtle. So even if a chest X-ray is normal, we tend to write in the report that the COVID is not entirely excluded because that needs further testing with PCR. So more cases. This is a 26-year-old female patient who basically presented with abdominal pain. You have to take my word that the chest, we did chest abdo-pelvis CT for her because of the abdo pain and find out the cause for the acute abdomen. And at the era of the COVID, we used to do the blanket chest abdomen and pelvis CT for these sort of presentation. She did not have any acute abdominal pathologies, but what she had was shown on this video here. As you can see here, there are multiple peripheral low predominant ground glass appearances in the chest. So this is a classic example of the mild version of the COVID, pulmonary COVID. So the and similarly, another patient is completely asymptomatic, nothing at all. I picked the scan from the normal oncology queue. The clinical history given was epigastric pain and weight loss. That's a chronic problem. And then, we did this chest abdo and pelvis CT just to look for any cause or any malignancy within the chest or abdomen. And what I've seen is shown in this video. There are subtle but more patchy ground glass opacities, and this time more towards the upper lobe, as you can see here and here. So very subtle ground glass opacities in completely asymptomatic individual. Then this patient went on to have an RT-PCR for COVID and turned out to be positive, but completely asymptomatic. So the next patient is a 51-year-old male who presented to our emergency with acute abdominal pain. And this was just probably around end of February, March time. At that time, we just used to have a chest abdo, not the chest abdo pelvis, but the simple, just a plain abdo pelvis CT. And as you can see it here, then what I meant to show is that there is thickening of the appendix with some inflammatory changes adjacent to appendix and the thickening of the fold, clear acute appendicitis. Surgeon took the patient to the theater, took the appendix out, was recovering in the ward, and then developed shortness of breath at that point. And then had a CT chest following that. Possibly surgeons were worried about PE. Yeah, and then that chest X-ray, that chest CT did show frank changes consistent with PE. So that's a hospital-acquired COVID infection in that young 51-year-old male. So next patient is 50-year-old male patient. Again, this was the case lent by one of my GP friend who came to the GP surgery with chronic cough, like 2-3 weeks of cough. Didn't go away. GP didn't think that was anything else, sent him home. Then patient came back again. The GP thought that possibly the patient is bonker. Let's have a chest X-ray done, and that's what the chest X-ray showed. So it's a bilateral, again, more towards the perihilar and peripheral consolidation. And this is not typical of the COVID infection, because we tend to see more peripheral ground glass and more low zone predominance, but here it's more the perihilar opacities here. Had a chest CT done, and again, chest CT, if we look at it carefully, it's more peripheral distribution, and there is no lobar predominance. It's just all over all 3 lobes of the lungs on both sides. So this patient has, in fact, never come as a positive RT-PCR test. This was thought to be, COVID, depending on the imaging appearances, and is still being treated in our hospital these days. Next patient. This is a quite interesting patient. He's 15-year-old, came with acute lung pain, leg pain, and fever. Everyone who has a fever gets a chest X-ray. That was his chest X-ray on admission. All you can see is the cardiomegaly. There's nothing in the chest, just cardiomegaly. And then because he had a fever and there was unknown cause of the leg pain, we decided to do chest, abdomen, and pelvis CT. And on that, what we can see is the pulmonary emboli, and also the infarction of the kidneys as shown in the arrow. So basically, this patient has later on turned out to be PCR positive for COVID, for coronavirus. So what the final diagnosis was, it's a COVID-induced myocarditis and microangiopathy causing the occlusion of the lower leg arteries, and then that's why the patient presented with the acute leg pain. So as you can see that the COVID can be present in a variety of clinical presentations. This is a 10-month-old child, came in with right iliac fossa pain and fever, and that was his CT. Basically, CT showed multiple mesenteric lymph nodes on the right iliac fossa with thickened bowel, as shown in the arrow, solid arrow there. The arrow on the CT showed a normal appendix. So this presentation was more like acute appendicitis picture, but the patient turned out to be RT-PCR coronavirus positive. So from these examples, you might have already known that COVID can present anything, like anything. There's no specific symptoms that can be relied on. Yes, chest symptoms in terms of cough and breathlessness is widely prevalent, but can present with like anything. I have seen the cases who has presented with a Guillain-Barré syndrome and turned out to be COVID related. So this disease is so difficult to predict, and it has got a variety of clinical presentation. Now, regarding the literature around the COVID, there has been hundreds, if not thousands, of the articles published in the literature just on the CT of the COVID patients. There may be, because of the lockdown, the people are getting more free and they have got more time and they got more time to publish. That might be the one reason, but I have not seen any other disease in the past who has gotten so much attention of the academic crew in the world. Let's go through some of the CT literature. So obviously, first two came out from the China. Those were the early days in late 2019, early 2020, and the subsequently Italian study, DOT study, came along, and that consistently showed that the sensitivity of the CT is very high, reaching up to 98% in some studies. Whilst the sensitivity of the RT-PCR test is quoted or reported as just over 70%. So CT has been shown to be quite sensitive in COVID patients. However, these results must be taken with a very cautious approach, because the sample size is so small, and the sample it's not randomized. All the patients are symptomatic in one form or the other in terms of the chest symptoms, and also the fact that studies have not used any specific criteria to say that, yeah, this is definitely COVID. So all the conclusions that has been drawn, that is high sensitivity of the CT, has to be taken with a pinch of salt in these studies. But the Chinese, they are so much into CT scanning rather than RT-PCR, because the specificity in the early literature was so low on the CT, they decided to do another study, and that study by et al. From China looked at particularly the specificity of the CT among like 7 different radiologists from China and United States. And what this study found was that the sensitivity can be up to 93%, but the specificity this time has reached up to 100%. So, again, the results should be taken with a bit of skepticism, because we don't know the experience of the reporting radiologists in these instances. The sample size was very low, of around 219. All of the CTs were in the symptomatic patients. So it's again not a reliable study, not a concrete or reliable study to depend on. But the Chinese are Chinese. They have already made up their mind that CT is a diagnostic tool for RT-PCR. So even before this study has come out, they have used CT as a primary diagnostic tool for COVID infection, and that is what happened until 12th of February. Chinese were relying just on the CT PCR, and then they relaxed the criteria to include CT features to be diagnostic of COVID, and that's what happened. Sudden surge of the number of cases in 13th of February, so much so that 2 of the Chinese officials have to be sacked from their job because they reported enormous high number of cases in China. Then come the study, which is basically a critical review of all the literature that has been published until end of March, early April this year. That was published in American Journal of Radiology. It's quite a reliable large study looking at critically reviewing all the studies that have been published about COVID and CT. And that study has finally concluded that COVID-19, in the diagnosis of COVID-19, CT has got no diagnostic role. Then after this study, or probably all the big giants were looking at all the studies that were so limited and weak, that now the 3 giants of the radiologists have come together and consistently said that CT should not be used to screen for or as a diagnostic tool for COVID-19. And that has come out quite late, probably middle of April or something. All of these unanimously said that, you know, CT is useless in diagnosing COVID. What is the role of imaging in COVID then? No imaging tool should be relied on in terms of diagnosis or screening for the COVID, but imaging can help personalize the management decision for the COVID patients, deal with the complications, and identify the alternative diagnosis apart from COVID in any CT or chest X-rays. The British Society of Thoracic Imaging has come up with this diagnostic algorithm or decision algorithm for patients suspected to have COVID. The only thing that I wanted to highlight was that it has not basically, even if the patient is suspected to have COVID, if there is no fever or no lymphopenia in the blood test, then there is no need of imaging at all. And if the patient is stable, then you don't need anything apart from chest X-ray. If the patient is seriously ill, and if the chest X-ray is quite classical of COVID, then you don't need any CT scan to manage that patient further, unless the patient develops some sort of complications whilst in the hospital, develop features of PEs and other empyema sort of complications, then we need CT, but otherwise we don't need any. So there are different patterns that that has been described in COVID. I'll quickly go through that. For any reporting radiologist or anyone looking at the chest X-ray in suspected COVID patients, I want you to remember 3 distinct patterns of the chest X-ray abnormalities. And this is a classic PE, which is basically peripheral lower zone predominant ground glass opacities without pleural effusion, without any lymphadenopathy in the chest. That's a classic PE. If you see that kind of chest X-ray, then you are sure that the patient is COVID, and you can say that it's a classical features or features consistent with classical COVID. And then there comes another pattern where there are some haziness, but you are not quite sure whether they can be just dependent changes, there can be some age-related, some COPD changes, just non-specific changes. Then you tell these kind of appearance as an indeterminate appearance of chest X-ray in diagnosing COVID. Whereas in some other cases, as in the third one on the right here, you can see frank abscess formation when it can be safely said that it's an alternative diagnosis but not COVID. CT pattern goes in the similar line in terms of normal, classic, indeterminate, and COVID. I'll go through some of the features that you should be actively searching for in CT examinations. So these are the typical ground glass appearance. You can see some degree of opacification at the in both lungs, but you can still see through the lung vessels and lung parenchyma. This is called ground glass appearance, and that's very this is the one which is required for any imaging to be said as a COVID positive or consistent with COVID. A few more examples of perilobular or reversible halo sign. As a reversible halo is shown in the dense arrow there, long arrow, and the arrowhead shows the perilobular pattern of haziness just around the pulmonary nodule, and these are thought to be quite specific for COVID infections. And if you see, like, ill-defined nodules on the image on the left-hand side, or the nodules which are conglomerated or centered around the bronchioles of the lungs, then that's a bronchocentric nodules. If you see these are indeterminate. These are very non-specific, can be seen in variety of other other viral infections or inflammatory disease like collagen vascular diseases and stuff like that. And this crazy paving is thought to be quite specific for for diagnosing COVID as well. So what you see is the ground glass appearance, but also see the thickening of the inter and intralamellar septa there. So that's a kind of crazy paving appearance, which is thought to be quite sensitive in being consistent with COVID infection of the lungs. And if you see something like this, where you cannot make out, yeah, you can see some haziness at the basis of the lungs bilaterally, but you are not sure whether this is dependent changes or some non-specific, then we call that as indeterminate for PE. So depending on the observation that you have made, then you come to the conclusion on the CT examination that whether that represents a classical PE with these features as outlined on this table, whether that comes under the probable COVID or indeterminate for COVID or non-COVID disease in the chest. So we characterize, or we come to the conclusion as to what we think the CT chest has shown. And sometimes it's quite important to quantify the score as well, both in CT and chest X-ray. And the only thing I want you to take you home from this talk is that if there are more than 3 focal abnormalities in the chest X-ray or chest CT, or more than 3 centimeter abnormality on either of these images, then that defines or quantifies the degree of severity. Less than 3 centimeter and less than 3 focal abnormalities, that's mild, and if there is more than 3, then that's moderate to severe illnesses. And severe illnesses are usually associated with crazy paving appearance, some architectural distortions, and things like that. But but just remember that rule of 3: if there is 3 focal or more than 3, then that's a severe PE, a severe COVID infection. And BSTI has come up with the guidance about how to report chest X-ray in COVID patient. Again, just find out whether that's, just infer from looking at the chest X-ray whether that's a classical chest X-ray feature, indeterminate or non-COVID disease, and then quantify the severity according to 3 centimeter focus or more than 3 focal infective changes in the lung parenchyma, and then issue the report according to the code that has been presented on the bottom of the slide, CVCX0 as a normal and CVCX3 as non-COVID disease. And similarly, they have come up with this guidance on how to report chest CT. Just look at the features of reverse halo, crazy paving and consolidation, and then bronchiocentric nodules, all those things that I've talked about. And then just after observing all those findings, just infer into which category or which group you want to put that patient on, either normal or classic or indeterminate or non-COVID, and then just describe the distribution, where exactly the changes are and the extent of the abnormality, just to tell them the severity of the disease. Again, if there are more than 3 focal abnormalities in the either chest CT or chest X-ray, then that's a severe disease. Again, they have given us the code to report, to put at the end of the report as to how to report, to code these sort of reports in the radiologist system. Now, talking a bit about the follow-up examination, and again, the 2 main things that we are worried about in COVID patients are development of interstitial lung disease long-term and development of pulmonary vascular disease. So the British Thoracic Society has come up with this guidance, which basically says that if the disease was severe to start with, patient requiring hospital admission, ITU admission, oxygen, intubation, all those things come into that category. And if that's the case, then we repeat the chest X-ray in 4 to 6 weeks, followed by another chest X-ray in 12 weeks. And at 12 weeks, if we suspect anything like interstitial lung disease, then we do a SRCT and send the patient towards the interstitial lung disease team. And if we suspect some pulmonary vascular disease, we tend to do like, again, SRCT, PFTs, and also like Swan-Ganz catheter pulmonary artery pressure measurement, and then take them towards the pulmonary vasculature route. Whereas in the mild to moderate case variety, we just repeat a chest X-ray in 12 weeks, and if the chest X-ray is abnormal, then we do PFTs, CTPAs, oxygen saturation on exercise and things like that. Whereas in severe disease, PFTs is mandatory in 12 weeks after the resolution of the symptoms or the discharge from the hospital. That's all I have to say about this. So thank you for listening, and stay safe, everyone, and stay equipped. Just have a look at the chest X-ray whenever you have an opportunity to do so, and quantify the disease. Find out whether that's a classical, indeterminate, or no COVID, and just try to quantify the severity of the disease. Thank you.
Thank you so much, Navaraj, for that. So I have got one question. You presented the sensitivity and the specificity results from the studies, very good sensitivity as you showed, but what was the gold standard? How did they confirm the patient was COVID positive? Was that the PCR?
The gold standard was PCR, yeah.
Okay,
yeah.
But we know from PCR itself, it has got the negative rate of
30%. Yeah, about 30% negative rate. Again, the most worrisome about those sensitivity reports were none of those patients were asymptomatic. And if somebody comes in the hospital with cough and breathlessness, and you do CT chest, and you are bound to find some sort of inflammatory changes.
Okay. Yes, exactly. Yeah, I agree. Well, I think that's
in the pinch of the salt.
So those 3 radiological societies you put, so that should be the one which changed our practice completely.
Yes, exactly.
Cancer cases, as a colorectal surgeon, I do a lot of cancer surgery, and we used to do CT chest as a part of screening about 48 hours before the planned operation, but we stopped that around the middle of May.
Yeah, middle of the May, because the virus, the prevalence of the virus in the community has dramatically dropped down, and then we had a more capacity to do the RT-PCR than to CT. That's the reason why those colleges and the Royal College and American College have dropped the recommendation of doing CT chest prior to the acute abdominal surgery.
No, I'm talking about the planned surgery. The planned cancer surgery used to do PCR as well as chest CT for screening patients to make sure it is safe for them to operate in the COVID-free environment. But once this guideline came in, then we stopped doing those chest CTs completely.
Yeah, well, guidelines, those studies consistently showed though high sensitivity, and one study showed high specificity as well. But again, the guidance is very weak. The evidence is very weak. And as we know more about the COVID as the days pass by, we are pretty sure that CT will not have any role in.
Thank you. So there is one question from Dr. Bandana Khan about use of dexamethasone. We know dexamethasone is in headline now. If somebody comes on with the GP practice, then you get a chest X-ray and you think it may be COVID, should you put them on dexamethasone? So my understanding about dexamethasone is it is beneficial in those patients who need oxygen and who need to go to the intensive care unit. But if they are mild without needing those things, then the dexamethasone is not beneficial. That's my understanding, but I'm quite grateful if there is any other comment.
Well, my understanding about dexamethasone is also like, dexamethasone has been shown to reduce the number of deaths in patients requiring hospital admission and oxygen treatment or ventilator, but the benefits of them for mild form of COVID disease, it hasn't been explored yet.
Is there any comment about that from anybody? You can just unmute and express your opinion.
I think that's my understanding as well, because I don't think the research has been published yet. We're basing on the news. So as far as I can read on the news, it was exactly what you just described.
Yeah, and about this research, I was listening to the interview to Professor Ewan Harrison from University of Edinburgh yesterday morning on my way to work. He's one of the surgeons as well. So it has been submitted to Lancet, being peer-reviewed. They may publish, probably they will publish, but if they don't publish, it will be published somewhere else, I think. So look like quite interesting and good study here. So any other comments, any other questions?
I think there's a question on the chat.
So from Dr. Bandana Khan, thank you. Dr. Manindra Srestha, if the patient is PCR positive for COVID-19 and CT pattern shows non-COVID pattern, what will be the diagnosis?
Well, I haven't come across that as yet, but the one explanation would be if the CT pattern is non-COVID, then we got to think about the complications of of the COVID, like complication COVID positive, had a bit of a ground glass appearances, then developed secondary infection and developed some effusion or lung abscesses and stuff like that. But if you see things like cavitation or pleural effusion or lymphadenopathy, then we are pretty much certain that that's not due to COVID.
Well, if the PCR positive, false positive is quite small with COVID-19, isn't it? So you will have to treat that as positive, I think.
Yes.
Even if the CT doesn't show positivity.
Yeah.
Okay. So then, so we have got altogether about 25 participants here. I would like to thank you, everyone, particularly from Nepal and Province 1, most of them. So it has been a long time, but I hope it has been useful. So I have learned a lot of things, particularly probably one thing I got in common, both from Wales and Province 1 is Province 1 is very low mortality in both of them. And it has been possible only with a lot of planning. Dr. Surya showed a lot of slides that look like a lot of hard work is done, and both the government and the public health and the team, the clinicians, are working together. I think that is the main lesson of success. Everything has gone into detail, attention in detail. That was very interesting to see that. And it is a great teamwork. And similar results in Wales as well, I think, compared with England, even better than Scotland. I think the Wales are doing very well as well. So with that, again, many thank you to everyone. And if there is any comment or any questions, if you unmute your microphone and say something, I would be very grateful.
I was quite impressed with all the work done in Province 1, and the planning. Obviously, as Dr. Surya Parajuli said, and same applies for Wales, is the key is the implementation, isn't it? So that's what often falls down.
So when you used to do this meeting around April, May time, you used to say Nepal has no mortality and we have got a lot of lessons to learn. I think it was true. Unfortunately, the cases are going up at the moment there. But let's hope it will come under control, whereas in the UK, the cases are still up, still about 150, 200 patients are dying each day. But that is slightly better than before, and hopefully we will get at the top of it. Many things Dr. Karki said, Dr. Surya said, a lot of those things. With those, we hope we can beat the virus. Then the dexamethasone has come, and eventually maybe we'll have a vaccine, as you said. So what I will do is I'll unmute all. Before that, Dr. Ramesh Koju, I would like to ask him to say a few words and maybe closing remarks. Then after that, I'll unmute all, I think. Yeah.
नमस्ते सबैलाई फेरि फेरि धन्यवाद छ। धेरै लामो समयसम्म बस्नु भएकोमा एटेन्डीहरुलाई पनि धेरै धेरै धन्यवाद छ। धैर्य धारण गरेर बस्नु भयो। जस डाक्टर सूर्यले हामीले धेरै इन्फर्मेसन दिनुभयो प्रदेश 1 मा के भइरहेछ। हामीलाई आशा छ अरू प्रदेशले पनि प्रदेश 1 बाट सिकोस्, किनकि प्रदेश 1 को इन्फर्मेसनले धेरै कुराहरू चाहिँ अरू प्रदेशले सिकाउँछ। अनुपलाई पनि धेरै कुराहरू चाहिँ हामीलाई बताइदिनु भयो, किनकि हामी क्लिनिसियनहरूलाई त्यतिको केही पनि थाहा छैन पब्लिक हेल्थको बारेमा। र हामीले धेरै चाहिँ अनुभव बताइदिनु भयो र के भइरहेछ। र नवराजजीलाई पनि, नवराजको एकदम राम्रो टक थियो। अहिलेको स्थितिमा अब हुन त हामी कहाँ कम भइसक्यो, तर नेपालमा आउँदैछ र नेपाली साथीहरू नेपालमा बस्ने चाहिँ कलिगहरूलाई चाहिँ धेरै महत्त्वपूर्णको चाहिँ विषय पनि हो। र अब म चाहिँ फेरि पनि तपाईहरुलाई धन्यवाद दिन चाहन्छु र कमलजीलाई चाहिँ अब लास्टमा।
Thank you. So I'll unmute all and let's clap and give thanks to all our speakers. Thank you very much. Thank you then. So I will, the